concentrate on your strength and not on your weakness. It's a normal tendency that if you concentrate on your weakness, that manifests. Okay. For example, if you go to the exam thinking that I don't know, it will come out of your mouth anyway because your mind is always thinking about it. Okay. 1. So be confident. 2. The purpose of all of us asking questions is that you get exposed to something, not to put you down. All right.
Yes, sir.
It's not to undermine your confidence. I understand a lot of these clinics should have been done in the second year with so much of classes, but it is all right. At least even now we are doing it, and not with an intention to put you down. That's all. Okay. And I personally had a feeling that you fellows are getting a little intimidated because there are too many people. That's a feature reason for which I have not called an outside faculty today. It's only me, Murali, and Ramachandra sir. And I think you will be comfortable with all of us. Okay. So I didn't get any external kind of faculty for this reason. Okay. So relax. Best of luck and go ahead.
And Ramesh, the exam which they are facing now is a theory exam. And theory exam is going to be a breeze for them. It's not a problem at all.
Absolutely.
They know everything about the theory. They should not have any issues at all.
Very true.
So
very true.
The recall rate will be very high, especially in a higher specialty subject. So I don't think you should have any worries at all. Even if you have not read the subject in the last 1 month, you will remember it because sometime during your course, you would have heard somebody talking about it. Okay. So theory is not a problem at all. That's what I have found. You will not have any issues with theory. Maybe 1 or 2 short notes you may have issues, but there also you will be able to answer. I don't think you should have any problems in answering the theory exam. Okay.
As an extension, I would also say that for practicals also it will be a breeze for a persons who have worked in the ward for this long. Okay. The problem comes only 2 things that you make unforced errors. That is, you tend to make by thinking too much. Your default setting is a pass for anybody who is working well in the ward. All 3 of you have done well. Okay. So relax. You will have to make extra efforts to fail. Okay. So unless you make an effort, we will not be able to fail you. Okay. Clear?
Yes, sir. Yes, sir.
So,
Yeah, sir.
relax.
One small extension of what you said. Always speak of what you practice in the ward.
Exactly. Lovely.
Okay,
Please,
so don't speak anything out of it. As sir said, it's very difficult to fail.
Yes, sir.
Unless you make extra attempts to fail. So that's it. Whatever you practice day in, day out, that's what you speak in the exam. That's it. Nothing else.
Yes.
Okay.
Yeah.
And work to your strength, because I realize each one of you have got a different strength. For example, for somebody, the concept may be a good, concept may be your strength. For somebody, language may be good strength. Don't bother about what somebody else has and what you don't have. It's okay. All you require to do is convey what you know. Okay.
Yes,
don't bother about language. Don't bother about grammar. English is not your primary language. If you don't speak English well, it is okay. It's okay.
Yes.
We are not here to do your English class. Okay.
Yes,
So certain things. This apart, one more thing I think I spoke to you yesterday personally. I want all 3 exam going students only to come and sit with me. I'll give you tips and writing, how to write a theory paper, how to make it more attractive, how to fetch more marks. As I told, I've been examiner at least some 20-25 times, so I know what is the generally other examiners also look for. All right.
Yes, sir.
Last but not the least, please understand, I'm in a very advantageous position and you are my children. I will not let you guys down. It is not that I'm going to simply pass you whether you're deserving or not. All I'm saying is we will be getting fair set of examiners. I have a lot of control in choosing the examiners because I am the board of specialties. I am going to be the university. But as a policy, I am not going to be divulging anything to anybody else. Okay. I know how things are working, but all I can tell you is that you'll have fair examiners, you'll have good examiners. Okay. You will not be disadvantaged to have bad examiners. You will not be having unreasonable examiners. Clear?
Yes, sir.
We are there to protect you, but only thing is we want you to pass on your own. You should pass because of the mercy of somebody else. Okay.
Yes,
and as a policy, I tell you, all my candidates so far, not without exception, I have not asked much questions except to pull them out if they're in a rut in the exam situations. Okay. And every single time, the examiners compliment me for the students, not for other reasons. Okay. I want to do that. Okay. So keep this in mind, just to keep yourself in confidence and present aram se, easy. Okay.
Yes, sir.
Go ahead.
Sir, patient name is Rishabh Bandal, age 5 months, male child, coming from West Bengal, whose informant is mother and reliability is good, came with complaints of increase in the size of head since birth. Presenting illness, mother antenatally underwent a scan at 30 week of age, where they noticed the increase in the head size. Later, at the 30th weeks of gestation, elective LSC is done in view of increase in the head size. After delivery, the baby cried immediately, started feeds on the same day, kept observation for 2 days in NICU, and they referred to tertiary care center for the same reason. There is a firstborn child. The birth weight during the delivery is 1.8 kilogram. And later, the mother failed to attend any tertiary care center. And during this period, the child, there is no history of fever, seizures, no history of excessive crying or refusal of it, no history of lethargy, drowsiness, no history suggestive of spinal abnormalities, and no history of difficulty in passing urine and stools. And the developmental history, currently the child having social smell, but unable to hold the neck and the head. But baby started on tablet acetazolamide and vitamin supplement 1 month back and currently on the same drug. Mother is antenatally registered and no history of any fever episode, exanthematous fever episode during the pregnancy. And family history, no other family members have the similar complaints. And after the admission in our hospital, baby underwent investigations, later underwent the surgery, ventricular peritoneal shunt insertion, and 4 days back. And there is no history suggested perioperative and postoperative complications. Currently, baby is on IV antibiotics and they having the normal direct breastfeeds. That's history is over, sir.
Okay, a few things.
Yes, sir.
A few things in the history. You said antenatal scan of increasing heads were told to the parents at 33rd week. Would you have asked for something else there? Whatever week, okay, 30th or 30th week, would you have preferred to ask a leading question after that?
I asked whether the scans at the 20th week anomaly scan is normal.
Very good.
Sir.
Very good.
And,
very good.
Yes, sir. And
then anything else?
Also asked apart from the head, sir, any swelling, any question related to the spinal anomalies there
Excellent.
or not?
Excellent.
Sir.
If you had told it, it would have been good. Okay, because it tells me your thinking process that yes, if a child has got a hydrocephalus, you ask for meningomyelocele. It's okay.
Yes, sir.
Fine.
Yes, sir. Yes, sir.
Second, the child underwent an elective cesarean section in view of the increasing head circumference.
Yes,
the
sir.
child was 1.8 kgs. So
Yes,
was
sir.
it a preterm delivery, a term delivery? Was it a low birth weight, or was it a preterm delivery with less weight?
Sir, it is a preterm delivery and it is appropriate for gestational age, sir.
Okay. Why was the baby delivered early? Because you said LSCS because of the increasing head circumference. Why did they? Because we had a lot of discussion day first today. I'm asking, why was the child delivered early?
Sir, according to mother, mother gave the history that since the head circumference that OGCN and neonatologist asked to undergo elective LSCS, sir.
Okay. Now I'm asking if you were to be consulted before birth for an antenatally diagnosed hydrocephalus, what would your advice be? What would be your thinking process?
Yes, sir. During the same week, I will also prepare for elective LSCS after injection dexamethasone to the mother for lung maturity.
What is the age at which? What is the stage of pregnancy? Would you like to suggest induction of labor or caesarean section?
After 32 weeks, I will suggest for induction of labor or caesarean section with the
Jaggu and Venki, will you agree with it?
Sir?
Jaggu and Venki, will you agree with it?
No, sir. I'll go as long as possible to get lung maturity. And as he said, I'll advise steroid for lung maturity.
Okay.
And I will think of, since it is I'm feeling that is a congenital hydrocephalus, I would consider, fetal drainage if facilities are available.
Okay, Venkatesh,
Yes.
any alterations in what they said, or the same thing you say? Same? Venki?
Venki is not yet joined, sir.
Okay, fine. Okay, my question to Sridhar, why do you want to have a preterm child? Say at 32nd week, you're going to deliver the baby, you're going to have problems of prematurity, and you're going to have hydrocephalus. Do you really want it?
Sir, in this child, increase the ventricular size is already the brain development is getting affected, sir.
Is it really going to get affected? That's what I'm saying. See, 32 and 36 weeks
Yes, sir.
would make a difference. Okay, I don't know what the literature says. My personal preference is if the baby is
Yes, sir.
32 weeker, the child's prematurity is so much that the child will have
Yes,
a
sir.
lot of struggle in the NICU because of preterm care. 36
Yes, sir.
weeks will be more comfortable age to deliver. Anyway, you're going to deliver by cesarean section, so you can plan
Yes,
it
sir.
and you can deliver
Yes,
is
sir.
my preference. And Jago,
Yes, sir. Yes, sir.
Jago, you said you're going to consider ventricular tapping. Okay, antenatal. One, how do you do it? Number two, what are the indications to do? Number three, what are the problems and complications?
Sir, antenatally, if it is compromising the, I forgot the indication. If it is developmentally, if it is not adequate, then we can consider.
You are
Sir,
very
actually, it
vague.
is
It's very
Sir,
vague.
percutaneous.
Because
study,
antenatally, what is the development that you're looking for? You don't know any developmental milestones.
sir, study shows that
Movement.
ventricular amniotic shunt as well as ventricular tapping doesn't help in the prognosis, improve the prognosis of the child, sir. So they
Thank
are
you,
not
Sridhar. We'll come back to you later.
suggesting.
We'll come back to you later. We'll come back to you in a minute.
Yes, sir.
Jago, go ahead.
Yes,
I think
sir.
Ramachandra sir is saying something. Ramachandra or Gopal or Murali. Okay.
So I wanted to affirm the same statement what you made. There is no
Yes, sir.
indication for early delivery
Absolutely.
in
Yes,
this
sir.
one. There's no indication.
There's no
Yes,
idea.
yes, sir. Yes, sir. Yes, sir.
One. And number two, what is the necessity for antenatal tapping? Sridhar or Jagu, how do you do it? Easy, difficult? One. Number two, what is the route through which you're going to do? Transabdominal, transcervical, ultrasound guidance, no ultrasound guidance? What is the risk of doing it? What is the advantage of doing it? When are the situations you will do it?
Hello. Sir,
Yes, Jago.
it is transabdominal, sir. Guided, ultrasound guided.
Okay.
So the risk of doing it is it can induce labor or otherwise bleed and infection.
Yes. Yes.
These are the anticipated complications, sir.
Okay. So when you have so much of complications, which all of them are significant, so what are the
Yes, sir.
stages would you like to do antenatal tapping?
Sir, usually not required, sir.
So you told me that. So I am asking you usually. So when is it the unusual situations where you will suggest?
Sir, very, very thin parenchyma, and if the child, the limb movements, rest of the things, if activity-wise, it is not good. I read it, but exact indications I forgot it, sir.
Okay. Murali, Ramachandra sir and Gopal can correct me if I am wrong. In my understanding, antenatal tapping is done only if one, the hydrocephalus is so severe. Number two, if there's not much chance for the child to survive and you just wanted delivery of the baby. For example, if it is going to be hydranencephaly or holoprosencephaly, such cases where you're really not sure about the child making it or not making, maybe just for sake of delivery, instead of doing a cesarean section, you may want a normal delivery. You can do a transabdominal tapping, but the risk is so high of infection, injury, okay, and so it is not routinely done. I've seen two cases which are delivered like this, where antenatally they thought child is a bad case, gone case, they tried a tapping, child was born. You should see the amount of injury the child had. In fact, it had gone through the somewhere near the ear, anterior to that, and it is a gory site. And worse, child did not die. Okay, and child they survive because the survival instinct of a baby is so high, it tends to survive. Okay, this is very difficult.
Yes, sir.
Gopal, Ramachandra sir and Murali, because I don't know what the literature says.
Yeah, I agree with you. No, there is currently there is no indication for draining antenatally either by one puncture or using a shunt. There is no indication for that.
Yes,
Okay.
sir.
So, and as Jagdish has pointed out, the complications of bleeding and introduction of infection, and also the technical expertise required to do it. So, it is not a very easy procedure to do. So, that is why it is abandoned. Nobody does it.
You have to also remember, Sridhar, that it's within the liquor amni, the head will be so much floating. In case of hydrocephalus, you will not have a cervical presentation. What do you call not a breech? What is
Breech
cephalic presentation? Breech presentation is more likely, so you can't do cervical row. You have to go transabdominal, and the head will be wobbling around within the amniotic fluid, so difficult to stabilize. So it is going to be difficult. Don't do it. All right.
Yes, sir. Yes, sir.
Next, I wanted to ask you was, you said the patient was started on tablet acetazolamide. Did the mother tell you that the child was started on acetazolamide?
Yes, sir. Mother told a Dimox tablet was there, and mother told the name of the tablet. That way I added.
Okay. So one, generally don't mention the tablet. Or alternatively, if I were to be in your position, I will use it to my advantage to say the child was started on some medications.
Yes, sir.
Leave it there, because that gives an opportunity for the examiner to ask you one question. Okay, one more question for which you know the answer already. You say, what is the medication likely to have been started? Then they'll say, you will say acetazolamide. Then they'll say how it acts, what advantages. You know what I'm saying? You are earning a lot of questions. By writing telling acetazolamide up front, one, you're losing the advantage of the questions. Number two, you're telling them up front and necessarily adding to the confusion. Not needed. Third, you said about a child has undergone a VP shunt. It is preferable at the history level not to tell the name of the surgery. Child has undergone a surgical procedure for the same. Leave it.
Yes, sir. Yes, sir.
And similarly, if a child is on IV antibiotic, you don't know IV antibiotics, IV medications, you don't know. Then the moment you say IV antibiotics, they'll say, when did this child undergo shunt surgery?
So 4 days back, mother told, sir.
Okay. So, 4 days back. It's okay. Otherwise, for example, they'll say, what is the antibiotic profile? You know, you're asking questions you're innovating questions which are not needed.
Yes, sir.
He has undergone surgery and is on medications with the same. Full stop. And if they ask, then it provides you an opportunity to go ahead. Okay. Thank you.
Yes, sir.
And if Murali and Ramachandra doesn't have much on the antenatal history, you can go ahead. But before going further, I have to tell you, your presentation today is very, very fluid. Very fluid. Very good. Very good.
Yes,
Murali.
This is one of the indications for doing an antenatal MRI.
Excellent.
Yes, sir.
Presence of progressive ventriculomegaly, it's an indication for doing an antenatal MRI.
Okay. Yes, sir.
Yeah.
Yes, sir.
Sridhar, what does antenatal MRI give you more information than an ultrasound?
Sir, it will also differentiate the presence of the arachnoid cyst or any malformation is present, sir. It also helpful in detecting any associated syringomyelia. This can be detected in the antenatal MRI, sir.
Okay. More than syringomyelia, please understand hydrocephalus can be primary or can be secondary to some other cause. Okay.
Yes,
Hydrocephalus per se is not a diagnosis, just like hepatomegaly or a pelvic ectasia. Hydrocephalus is a manifestation that is secondary to either aqueductal stenosis or dandivacal malformation or a choroid plexus cyst or a mass or a whole, so many other things. So by what Murali said, if you do an MRI, it will give a picture of what are the things which can be there and will give you help in prognosticating the case and counseling them. Okay. Okay.
Yes, sir.
Go ahead.
Sir, on examination, baby is conscious, alert, active, afebrile, no pallor, no cyanosis, no clubbing, no lymph nodes palpable. Vital signs: heart rate is 120 per minute, respiratory rate is 30 per minute. Anthropometric weight is 7.8 kg, more than the expected weight. Length is 55 cm, normal to age, and head circumference is 58 cm, more than the expected. So, on examination, the head circumference is head size is increased with head circumference of 58 cm. Anterofrontal is wide open and it is depressed. And it is flat. Cranial sutures are separated. Posterior frontal is also opened. Scalp veins is visible. It's a bandage present in the right temporal region. And shunt chamber palpable in the right mastoid region, and it is compressible. Eyes, there is a downward gaze is present. Sunset sign positive. There is no nystagmus, no neck rigidity. On examination of abdomen, there is a transverse scar of around 2 cm present in the right hypochondrial region, and there is a reducible swelling of 1.5 to 1.5 cm present in the umbilical region, which increases while child crying and decreases when the child is calm. On palpation, there is a defect in the umbilical region of size 0.5 cm. And the external genitalia examination normal, perineal orifices are free, spine examinations are normal, other upper limb, lower limbs are normal. Coming to diagnosis, 5-month-old baby with antenatally detected increase in the head size and postnatally there is increase in the head size, progressive increase in the head size, with no history of seizures and sepsis, with examination findings suggestive of congenital hydrocephalus, which is congenital, probably non-communicating type, status ventricular peritoneal shunt in situ with umbilical hernia.
Murali and Ramachandra sir, please ask questions, then I will join.
Okay, Sridhar, you said anterior and posterior fontanelle. What about the lateral fontanelles?
Since I checked with her, but I am not able to separately felt that lateral fontanelle. But its overall sutures are separated. So probably lateral fontanelle also felt, but I can't able to make out.
So normally one question which will be asked is what is
Yes,
the
sir.
sign of a hydrocephalus, a subtle hydrocephalus in a newborn? Like, head circumference being almost like 95th centile of the normal. And
Yes,
what is the sign that there is hydrocephalus in this baby without an ultrasound?
Sir, it's a crackpot sign with McEwen sign is present.
No, that is because of
microseparacy.
very huge this thing. When head circumference is
Yes, sir.
almost normal, like 95th centile, almost normal,
Yes, sir.
or maybe
Yes, sir.
higher limit of normal.
Yes,
So
sir.
there is a suture called as the lambdoid suture. Sorry, aware of
Yes,
that
sir.
lambdoid suture?
Yes, sir. Yes, sir. It is the posterior coronal suture.
No, lambdoid suture is felt on the side.
Yes, sir.
Okay. Between what and what bone?
Sir, between the occipital bone and the two parietal bones, sir.
Correct.
Yes, sir.
Okay. So that lambdoid
Yes, sir.
suture will usually be fused in all newborn babies.
Yes, sir.
Okay,
Yes,
that
sir.
is a anatomical fact. Lambdoid suture
Yes, sir.
will be fused. So when
Yes,
this is a subtle sign of hydrocephalus where you won't have
sir.
the fusion of the lambdoid suture. So lambdoid suture will be open in spite
Yes,
of the
sir.
head circumference being almost normal.
Yes, sir.
So then when you do the this thing ultrasound, you may find hydrocephalus in this baby. Okay. So
Yes, sir.
lambdoid
Yes, sir.
suture being open is one of the subtle signs of hydrocephalus. Okay.
Yes, sir. Yes, sir.
And
So
as
in
an
the
extension,
exam,
yeah, please.
yeah,
Sir,
in
go ahead,
exam
sir.
they
Go
may
ahead,
be
sir.
asking you what investigation you will do if you get this baby without surgery, before surgery. Yeah, Ramesh, you go ahead.
Good, sir. Okay, as an extension, I think, what is the earliest feature of raised ICT?
In neonate, there is increase in the head circumference with anterior frontal bulging will be the earliest sign, sir.
Apart from bulging of anterior fontanelle, something else which can be settled. For example, this particular child, okay,
Yes,
has got a hydrocephalus, has been operated, okay,
yes,
4
sir.
days back. Child has got a
Yes,
wide AF, posterior fontanelle open, that is not going to come down rapidly. You cannot check
yes,
the
sir.
function of the shunt because the shunt area is edematous and tender. Still, in the
Yes,
ward, you want to know whether the shunt is functioning or not. So, what are the things you look
yes.
for? Jagu?
I will check for the anterior frontal bulging or anterior frontal flat, and I will check whether the pulsation is felt on the anterior frontal.
Yes.
If the
Most
pulsation
important
is
is
felt,
the pulsatility of the anterior fontanelle. Normally,
yes, sir.
if you make the
Yes.
child, how will you check the child's AF pulsatility? In what position of the baby? Jagu. Okay. You have to keep the child erect. When the child is sitting,
Correct.
just look
Yes,
at
sir.
the AF. In a
Yes,
normal
sir.
child with less AF, anti-intracranial tension, you will see the AF being pulsatile. Whereas
Yes, sir.
in a hydrocephalus, AF will not be pulsatile. Say, for example, go to the ward and see this child again. For example,
Yes,
after
sir.
the shunt, you would have seen that the
Yes, sir.
pulsatility of the AF would have been restored. So the earliest
Yes,
subtle
sir.
sign is loss of pulsatility AF. Okay.
Yes, sir.
What is the reason for that pulsatility, Sridhar?
Sir,
Sir, it is a transmitted pulsation, sir.
No.
Transmitted.
It is transmitted, but what is the reason for it? The normal brain is pulsatile. Normal brain is
Yes, sir.
pulsatile. Okay.
yes, sir.
When the brain is having a lot of pressure inside it, it loses its pulsatility. Okay.
Yes, sir. Yes, sir.
So if you have done some neurosurgery posting, you will know that when you do a burr hole and open, you will find that
Yes, sir.
the brain is a pulsatile organ. Okay, you'll see the pulsatility of the brain when you actually open the dura and see. Okay,
Yes, sir.
Yes, sir.
pulsatility is a normal function of the brain. This is one of the few
Yes,
organs
sir.
where you can actually see the pulsatility. If you
Yes, sir.
do Doppler, all organs will be pulsatile, but brain is the one where you can see the pulsatility when you actually
Yes, sir.
observe it. Okay, it's the brain
Yes,
pulsatile.
sir.
All right.
And
Yes,
as
sir.
an extension, even when you're doing a regular exam, a VP shunt, you make a burr, just even if the pulse, this thing is not pulsatile, the
Yes, sir.
CSF leakage through that, or whatever you have done, will be
Yes, sir.
pulsatile. The moment you make a
Yes.
hole in the dura, you'll see
Yes,
the CSF is not freely flowing.
Yes, sir.
Especially in a hydrocephalus, with the pressure being high, you will see it coming out. But in
Yes,
a
sir.
normal child, or once a shunt is done for revision, or if it comes down, you'll see the
Yes,
CSF
sir.
actually coming out at the pulsatility. All right.
Yes, sir. Yes, yes, sir.
Okay. Next thing I want, you finished the exams, no? Okay.
Yes, sir.
Next thing I wanted to ask was, you talked about fontanelles. Now tell me a little more about which fontanelle closes when. What is the age at which you expect it to be formed, and what is the
Yes, sir.
significance of each of the fontanelle being open?
Yes, sir.
How many
Sir,
fontanelles are there totally?
sir,
How many fontanelles?
anterior sir, totally there are there are totally 6 fontanelles is there, sir.
Very good.
That's
Which are they?
anterior, posterior, and 2 lateral on either side.
Okay, good.
So, anterior fontanelle is formed by the parietal suture and the coronal suture at the junction of the parietal and coronal suture, where
Okay.
it closes by 18 months to 24 months. That is 1.5 to 2 years of age. Normally, it will
Okay.
closes. Where
Okay.
posterior fontanelle is between the lamproid suture and parietal suture, where it closes by second 2 to 3rd month of the age.
Sure.
Where a lateral,
Postnatally 2 to 3 months of age.
yes,
Posterior
sir.
fontanelle. Murali, I
Yes,
don't
sir.
know.
It is,
I was under the impression that it actually is closed generally at birth. If it is open, it is significant. Murali?
but it is
3
when
months,
it
yeah,
will
it
close
closes. 2 to 3 months.
2 to
That is
3
correct.
months, yes, sir.
Okay.
Yeah.
And lateral fontanelle lateral fontanelle is between the sphenoid, temporal, parietal, and frontal bone, where the terion is present. In that fontanelle will closes by birth. Sometimes it will closes by 2 months of age also, sir. Lateral fontanelle.
Correct me if I'm wrong. In generally, the lateral fontanelle is closed antenatally. Posterior fontanelle is closed around birth time, maybe a little earlier or a little later.
Yes,
Anterior
sir.
fontanelle is closed by 1 to 1.5 years of age. Murali, am I right or any
Yes, sir.
changes?
And posterior fontanelle closes by 2 to 3 months, and then anterior fontanelle, what you said was right. Lateral fontanelle, again, it depends. The anterior lateral fontanelles, they close a bit early than the posterior lateral fontanelles.
Okay.
Yes, sir.
And what is the significance of the fontanelles being open?
Sir, if the fontanelle is opened, it probably indirect evidence of the increase in the increase in the pressure in the ventricular system.
Okay.
It indirect evidence of hydrocephalus, sir.
I understand. I'm giving a different scenario, Sridhar. You got one
Yes, sir.
child where only anterior fontanelle is open. Then another child is there where posterior fontanelle is open. Then there's a third child where anterior, posterior, and both the lateral fontanelles are open. What is the clue that you get out of the three? What does it imply to you?
Sir, age of the child, sir, if the first child only anterior fontanelle open, that will be a normal child, sir, if it is less than 2 years of age.
Okay.
If anterior fontanelle, lateral fontanelles all are open, there will be a significant hydrocephalus may be there, which can be, we need to check, sir.
Jagu, anything you want to add? Jagu?
Not much about fontanelle, sir.
Okay.
I'll read, sir. I don't know
Okay.
about fontanelles.
See, it's simple.
Yes, sir. Yes, sir.
If
Yes, sir.
anterior fontanelle alone is open and bulging, it can be either congenital or acquired hydrocephalus. Posterior fontanelle is open. Generally,
Yes,
it
sir.
is prevented. That means it may be antenatal hydrocephalus or congenital hydrocephalus. But if the lateral
sir.
fontanelles are open, that means there's a raised ICT even during pregnancy. Okay, that
Yes,
means
sir.
either it's one, as I said, is a severe hydrocephalus. Second, definitely
Yes,
it's
sir.
a congenital cause where the hydrocephalus
Yes,
started
sir.
very early in gestation. All right.
Yes, sir.
That
Yes, sir.
gives a clue.
Yes, sir. Yes, sir.
And then in the history, you also said the child has an umbilical hernia.
Yes, sir.
What is the significance in this case?
Sir, the significance is that since the child underwent ventricular peritoneal shunt, sometimes this umbilical hernia won't get reduced by itself, sir. There is an increased chance of umbilical hernia to persist
Okay.
when compared to the normal child with umbilical hernia, sir.
Anything else? Could it be the child did not have an umbilical hernia and it must have got opened up after amputation? Is it possible?
Yes, sir. It is possible, sir. Yes, sir.
Okay. So whenever there's a raised pressure, umbilical hernia, one which is not present could present, or if it presents,
Yes,
it may
sir.
not be healing faster. What are the other features
sir.
of raised intra-abdominal pressure following a shunt?
There will be ascites will be there. Another there will
Maybe
be
there.
inguinal hernia. Ascites may be there. Inguinal hernia may be there.
Hernia
Sorry,
or
not hernia. Sorry, sir. In hydrocele may be there, sir.
hydrocele may be there. Okay. And what is the
Yes,
implication
sir.
in case the child develops a hernia on one side? What will you do? What are the
Yes, sir.
implications?
Sir, if the child developed hernia on one side, I will go for bilateral herniatomy because the chances
Yes.
of side also getting hernia is more, sir.
Yeah.
And there is also chances that the VP shunt tip can migrate into the hernial sac and it will give you the complications. So better I will go for bilateral herniatomy.
Okay. Done. Last I wanted to tell is when you said about McEwen sign or that what you call crackpot sign.
Yes, sir.
What is the prerequisite? When does it come? Will you be able to elicit in this child?
Sir, if there is a cranial suture separation is present, then we can able to elicit the sign, sir. In this
Okay.
child, since the sutures is open, can be able to elicit. But I didn't check because child was excessive crying, so I didn't check it, sir.
Okay. Sridhar and rest, I am a little confused. I was under the impression that McEwen sign or a crackpot sign is seen only after the AF is fused. Okay. And
No.
fluid circulation earlier. Maybe I'm wrong. Please correct me if I'm wrong. Murali and Ramachandra sir, please.
I don't have much idea about this, sir. Sorry.
Okay. In that case, Sridhar, read about it and please let us know. Okay.
Yes, sir. Yes, sir.
There's a Nelson's book textbook in the same room that you're there. I've kept a Nelson
Yes,
textbook
sir.
there. Please read it
Yes, sir.
about
Yes.
McEwen sign and let us know. Or Jagu, if you're
Yes,
there in the
sir.
room, or somebody else, Vinu or Vandana, just check it and before the end of the presentation, please let us know what is McEwen sign and what are the features of hydrocephalus, clinical features. All right.
Yes,
Go
sir.
ahead. Go ahead.
Sir, I have
Murali?
a small doubt, sir.
Yeah. Sridhar, you
in the taking
examined
of
the spine.
Yes, sir. Yes, sir.
What were you specifically looking for?
Sir, I checked for any neurocutaneous marker is present.
Yeah.
So that there will be
Correct.
chance. Yes, sir. Yes, sir.
Right.
Spina bifida occulta.
Yes, sir.
Okay. So if you had mentioned about that also, it will be good because it's conveying to people that you're look for it and it is not there. All right.
Yes, sir.
Okay.
Yes, sir.
Go ahead. Go ahead.
Sir, I have a small doubt, sir.
Please.
Can we repair the umbilical hernia now, because we are expecting that the spontaneous closure in this case is be unlikely. So can we, while doing shunt only, can we repair umbilical hernia in a single sitting?
So far, nobody has thought about it. Thanks for letting us know, but I don't think it is worth doing it unless it's symptomatic or irreducibility. Because even though there's a raise in the ICT, I mean intra-abdominal pressure, this is only transient. The body adapts as soon as the absorption takes place. So all cases of shunt do not develop a hernia, and all of them do not develop an umbilical hernia either. So we don't know.
Yes.
So unless it's really needed, it generally goes against the principle
why
of
I am
surgery.
asking is it's already present. The chance of spontaneously reducing is very low. As we know, is it really worth doing in the same sitting or not? And just I had a doubt.
Jagu, good idea, good question, but unfortunately, as much as I can think now, I don't think I will do what Ramachandra sir and Murali say.
No,
Sir,
there is,
regarding in this answer, the chance of reducing is less when compared to the normal infant, sir. But definitely the chances is more chances it will get automatically reduced. But it is less when compared to the normal child. So still we can wait, sir. Manage
That's
the
what I also
conservative.
thought. So what
no, there is
Sir Ramachandra sir and Murali?
there is no recommendation for closure
Yeah.
of umbilical hernia
Yeah, you
if
can
it is
wait.
present in a patient with VP shunt. There is no recommendation for that. Okay.
Okay.
Whereas there is a
Yeah.
recommendation for early closure
Inguinal
of
hernia.
early herniatomy, even in a congenital hydrocele, and also to do a
Yes, sir.
contralateral exploration and close a patent post vaginalis if it is there.
Fair enough.
That
Yes, sir.
recommendation is there. Even if the hydrocele is discovered before the age of, say, 10 months or whatever, when your
1 year.
spontaneous regression is expected. Because spontaneous regression will never occur in a baby with VP shunt.
Yes, sir.
So it will persist. Congenital hydrocele will persist beyond the age of 10 months when it should spontaneously regress in most patients.
Okay,
Yes,
sir.
sir.
Thank you, sir.
Okay, Sridhar, go back to telling the diagnosis alone and then we'll start the management.
Diagnosis: congenital hydrocephalus, probably non-communicating type, status ventricular pentatonal shunt in situ with umbilical hernia.
What makes you say there's probably non-communicating type?
Sir,
What in the clinical
since,
features or history made you say
yes,
that
sir.
this is perhaps a non-communicating hydrocephalus?
Sir, since most of the congenital hydrocephalus will be a non-communicating type, as cerebral aqueduct stenosis is the most common type, sir.
I agree.
Rarely,
But for
yes,
you to
sir.
commit in a diagnosis, you
Yes,
should
sir.
have definite features to suggest that. Do you have?
Definite features I didn't have, sir.
No. So it is better not to commit about it. Okay.
Yes, sir.
On clinical examination, is there any
Yes,
subtle
sir.
sign to suggest that this could be a aqueductal stenosis or this could be Dandy-Walker malformation? Because both of them will have hydrocephalus clinically.
Yes, sir. Sir, in case of architectural stenosis, there will be a suprastentorial ventriculomegaly will be seen. So size of the head will be more at the cranial side, where uniform increase in the size of the head present in the Dandy-Walker malformation, where both the
I agree.
supratentorial ventriculomegaly and the posterior fourth ventricle also will get dilated. So
I
clinically we
understood.
can differentiate, sir.
Yeah.
Yes, sir.
Clinically, head will be more oblong in case of congenital hydrocephalus because of equilateral stenosis. In the case of
Yes, sir.
Dandy-Walker malformation or Dandy-Walker cyst, what can happen is the occiput is also bulging. So it will be uniform
Yes, sir.
or
Yes, sir.
rounded appearance rather than an oblong one. Good one. Good answer.
Yes, sir.
Good answer.
Yes, sir. Yes, sir. Yes, sir.
So I would suggest you not to mention about the cause of the hydrocephalus because at this stage you
Yes,
don't
sir.
have any evidence. So
Yes, sir.
you don't volunteer. Okay.
Yes, sir. Yes, sir.
Okay. What will you do?
Sir, when the child comes with this history, I will do investigation
Okay,
to confirm the diagnosis, sir. Yes, sir.
now we'll put
Yes.
two scenarios. First scenario is
Yes, sir.
I want to put a hypothetical case that this child has not undergone a shunt surgery. Okay,
Yes, sir. Yes,
this
sir.
child has primarily presented to you about 1 week back.
Yes.
Now you tell, and then we'll come back to shunt later.
I will go through the antenatal scan report, sir, initially.
Very good.
And after the antenatal scan reports, to confirm the diagnosis or to look for any associated anomalies, I will go
Once
for
again,
ultrasound of brain.
once again.
Yes, sir.
In the antenatal scans, what are the things that you're going to specifically look for? That the child has got a
I will.
hydrocephalus now. That the child's
Yes, sir.
mother gives a history of antenatal hydrocephalus. You know definitely
Yes,
the
sir.
diagnosis is going to be hydrocephalus. Why do you want to
Yes,
see
sir.
the report again?
Sir, I need to see to look for any other malformation associated with the antenatal hydrocephalus, like if the
One.
presence of the cyst or any spinal anomalies is seen.
Okay. So you're going to look
And
for any associated things then?
yes, sir. And then
Anything else? Which actually you covered during your history presentation itself.
yes, sir.
Jaggu, you're free to answer anytime you want. Also, you can also tell about what is the onset of hydrocephalus. Okay.
Yes,
The
sir.
hydrocephalus,
Yes,
if
sir.
it is early or late onset
Yes, sir.
hydrocephalus, also can tell you
Yes, sir.
about the possibilities. Okay.
Yes, yes, sir.
So one, you find out about the onset. Number two, you find out
Yes,
is there any features of secondary hydrocephalus, and then you can
yes,
manage.
sir.
Okay. That's
Yes,
all
sir.
normal. Now you go ahead
Yes,
and
sir.
get a, next you said you wanted an ultrasound.
Yes, sir.
What are the advantages of an ultrasound? What is the disadvantage of an ultrasound? And what are the things that you can find out on an ultrasound?
We have reached a stage where we
Yes, sir. Yeah, I will do ultrasonography to look for ventricular size and ventricular hemisphere V by H ratio, and also I will look for size of the third ventricle and fourth ventricle, associated malformations like presence of the cyst, any space occupying lesions, and cerebral mantle thickness. These are the things I will measure, sir. Together, I will go for ultrasound spine to look for any anomalies. There, I will get those.
Excellent, Sridhar. You answered beautifully.
Yes,
Lovely, 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 lovely. I am impressed. Okay, just to add a question, what is the normal
yes,
VH ratio and which is it alarming to you?
Sir, normal VH ratio is less than 0.4, sir. If it is greater, goes beyond the greater than 0.6, along with increase in the resistive index, it will be alarming situation.
Excellent, excellent, excellent. Murali, if you don't have question, we'll go ahead.
Sure, sir.
Okay. So what do you do next? Okay, ultrasound gives that this is a case of Vinu or Vandana. You want to give a picture or okay, you got a scan. Good. Present.
Sir, this is the antenatal scan, sir.
Okay, you read the report. Tell me what you infer out of it.
Sir, antenatal done at the gestational age of 32 weeks. It shows bilateral lateral ventricles are grossly dilated with a maximum diameter of 31.7 millimeter. Unseen communicating with third and fourth ventricles, suggestive of communicating hydrocephalus. Diffuse thinning of brain parenchyma is seen. Posterior fossa is small in size. Bilateral cerebellar hemispheres are seen. No other congenital anomalies seen.
Okay. So what
Yes,
do you infer out of this?
Sir, in this scan, it shows that all the lateral and third and fourth ventricles are dilated, sir. And but also mentioned the bilateral cerebellar hemispheres are seen. There is no agenism thing. So if this mother presented antenatally, I may went for MRI scan, fetal MRI scan.
Okay.
So, but I will reconfirm my diagnosis by doing a check for these anomalies again with the ultrasonography, sir.
Okay, we had a lot of discussions day for yesterday about antenatal interventions and antenatal workup.
Yes, sir. Yes,
See, for example, if your ultrasound is so explicit about all the things that is being told, what additional information you're going to get out of MRI, which is going to influence your decision?
Sir, if additional
Incidentally,
yes,
Sridhar, I'm asking this question because you answered very well. So this is a price question. This is not the normal question that we ask in the exam. Okay.
Yes, sir.
Okay,
yes,
go
sir.
ahead. That means you're doing very well.
Okay, sir. Sir, additionally, I will go for MRI to look for associated anomalies, sir. Because ultrasound is not sensitive detecting all the anomalies, sir. If associated anomaly like Dantivarkar and cherry malformation, if I see, it will helpful for prognosis, helpful to explain the prognosis to the mother, parents. To explain prognosis to the parents, it will be helpful, sir.
Okay, for example, this child is at 32 weeks and you're doing an MRI. Will it help you to make a decision antenatally?
No, sir. Here it won't be helpful.
Why?
Because any interventions like ventricular amniotic shunt is not useful. It was done yesterday. It won't be useful, sir. And another medical termination pregnancy is not possible at 32 weeks, sir. So
3. What is the gestation of the child and what does it imply to you?
Sir, gestational age is 32 weeks.
So what does it imply? It implies that the fetus is viable. So it's no more a question of just a feticide. It looks almost like an infanticide. I'm not talking morally. That means the child is capable of independent life. Okay, child is already having all the things. So it is going to be like a normal delivery. So this is the time when termination is out of question. Delivery is going to be as good as normal delivery. Okay, or a cesarean section. And if they decide that I don't want to take a baby, it means it's as good as going through delivery and losing the baby just like that. Okay, so these are the situations where you can just suggest that you can wait for a little longer and do. Just as a paradox, just as an addition, I would like to say, just this Monday, this is standard. 5 days back, I had seen a child which had a late onset hydrocephalus. Fifth month scan was normal. 7th month scan showed hydrocephalus, and 32 weeks it showed a significant hydrocephalus. Lateral ventricles dilated, third ventricles query, lateral, and nothing else. Okay, the thinning of cortical parenchyma. What would you have given the counseling for that baby mother? 32 weeks, similar situation. Gross hydrocephalus, cortical thinning.
Sir, since the child, I will counsel the mother that since the child is past the viable stage, to continue the pregnancy for next 3 to 4 weeks and then go for a elective induction of the labor, sir.
Okay, exactly the same condition I told them, because at 32 weeks delivering the baby now is going to, because the child is already viable. Delivering a baby means it's going to be an extremely preterm child fighting for both premature related issues and hydrocephalus will be a stain on the parents. and it'll be difficult. So I suggested, having come this far, might as well continue pregnancy for 4 more weeks and then deliver. As
Yes,
things
sir.
would have it, they forced the gynecologist and they delivered the baby. Yesterday,
Yes,
day for yesterday, I got a call. 32
Yes,
weeker,
sir.
now having RDS, they don't know what to do, and baby is refusing to die. Okay, they expected.
Yes.
So these are the issues that will happen. So you need to counsel
Yes,
them
sir.
well enough. That's what I would like to highlight. Okay, good.
Yes, yes, sir. Yes,
So
sir.
you do an MRI, and then it
Yes,
will
sir.
also one prognostication, as well as it can tell you about the mode of delivery, about the quantity of hydrocarbons. Yeah, go ahead.
Yes, sir.
Oh, they've done MRI, is it?
Yes, sir.
Okay, go ahead.
Yeah. It is, sir. It is postnatal MRI. It is now only, not antenatal.
Okay, okay.
Yes,
So
sir.
don't go to this now. Okay, postnatally you've done it. Is it showing anything different?
Yes, sir.
MRI?
Yes, sir. Yes, sir. Yes, sir.
What does it say? Postnatal pre-operative MRI, right?
Pre-operative MRI. Yes, sir. But image postnatal MRI.
You just projected, no?
No,
Okay, tell the
nuclear
report. Tell the
projected.
report. That's okay. Tell
I
the
don't.
Vinu, just tell the findings. That's all.
Yes, sir. It shows supratentorial ventricles are morally dilated, causing compression over the brain parenchyma. Gross thinning of corpus callosum is noted. Basal ganglia and thalami appear normal. Myelination of brainstem and middle cerebellar peduncles are consistent with age. There is a large posterior fossa cyst with a non-visualization of inferior part of cerebellar redness, though which continue with a prominent fourth ventricle, suggests the anti-Walker variant. And no acute infection. Particle sulci, Sylvian fishes, basal systems are normal. Cellular and paracellular regions, optic tract, chiasma are normal. Internal auditory canal, 7th and 8th nerve complex normal. Others are normal. So impression is the anti-Walker variant with the moderate communicating hydrocephalus. It is mentioned, sir.
Okay. So what is the difference between a Dandy-Walker cyst and a Dandy-Walker malformation?
Sir, in Dandy-Walker malformation, it is associated with the cerebellar inferior vermis agenesis, sir. Where cyst is only a posterior fossa cyst will present with the development of the cerebellum.
What is the basic problem in a Dandy-Walker cyst or a malformation? Why does hydrocephalus happen?
Sir, the cyst also will causes compression or agenesis of the foramen Lashkan magenti. It will prevent the CSF outflow fracture. That is the reason for
There's an obstruction in foramen of magenti Lashka. Okay.
Yes, sir.
So
Yes, sir.
of the foramen of magenti Lashka, which is middle, which is lateral? Or how many of them are there?
Sir, 2 level is Lashka, 1 medial is the magenti. Total 3 is there, sir.
Okay. Simple way to remember: M is median,
Yes,
is and L is Lushka is lateral. 2 of them.
Yes, sir. Yes,
okay,
sir. Yes,
easy.
Sir. Yes, sir.
Okay. Okay. This child has got a Dandy-Walker cyst, no?
Yes, sir. Yes, sir.
And so, what is the management for it? What is the management would you like to do?
Sir, initially it was advised to undergo the CSF diversion, ventricular peritoneal stent is advised, sir. Initial management. After the ventricular peritoneal, yes, sir.
Yeah, go ahead.
If the ventricular peritoneal stent, the child is able to capable with child is with ventricular peritoneal stent. If the development of the child is normal, post-operative, there is no problem. We can observe the child. But in spite of the VP stent, if the child is having neurological deterioration, they will ask. There will be other procedures like cystoperitoneal stent, endoscopic cyst, endoscopic procedure. These are the various methods can do, sir. So initially advised to go VP stent followed by observation.
Okay, Murali, any questions?
Nothing, sir. Usually people used to do what is called as a Y shunt. They used to put one separate tube into the cyst and one into the ventricle. And they used to connect it to a common connector, and then that used to be put into the peritoneum. That's called a Y shunt. So there is one. As I said, now people have come up with ETV and all these newer modalities. So that's fine. I mean, this is for Dandy-Walker cyst.
Yes, sir. But why shunt? How can they guide the adjunct to the posterior fossa, sir? That is a fourth ventricle. Just a doubt because is it possible to guide to fourth ventricle, sir?
Yeah, because it's dilated.
Because
No, it's not a normal fourth ventricle we are dealing with. It's a dilated fourth ventricle. It's formed a huge cyst.
yes, sir. Yes, sir.
Yeah. So a huge dilated cyst, obviously you can put it into the cyst. That's not a problem.
Yes, sir. Yes, sir.
Sir, entry point is from the same burr hole, sir.
No. They usually do two different burr holes.
Okay, sir.
Yes.
Yeah, just a second. Just a second. I had some power issues. I just switched on the power.
Yes, sir. Yes, sir.
Can you hear?
Yes, sir. Yes, sir.
Okay. So what I'm asking is, see, basically you said the basic problem in this case of Dandy-Walker malformation or cyst is that the
Yes, sir.
foramen of Magendie and Lusk are blocked. In what
Yes,
way
sir.
either an ETV or a VP shunt is going to help the baby?
Sir, VP shunt will divert the CSF from the lateral ventricle to the peritoneum, so the pressure in the ventricles will reduce. For ETV, they will make a connection in the third ventricle to the subarachnoid space. They will make a connection, sir, in between the mammillary bodies and the infundibular reaches, sir. So that also will decompress the
I know,
ventricular
understand the
pressure.
pathology.
Yes, sir.
Understand,
Yes,
but
sir.
the basic problem is a cyst in the posterior fossa,
Yes, sir.
right? There's a cyst in the posterior fossa which is blocking the foramen of Magendie and Lusk. Okay.
Yes, sir.
My question is,
Yes, sir.
how will a shunt address the primary
sir.
problem? It is just addressing the second issue. Understand? There's a raised density, brain parenchymal
Yes, sir.
development may come down. That's why you're putting a shunt. Whereas the
Yes, sir.
Dandy-Walker cyst per se is still persisting.
Yes, sir.
How does it address?
Sir, once we get decompressed, the cyst won't cause any, not all, but most of the cyst won't cause any compression problems, sir. No compression abnormality. So we can be observed, sir. But if it causes compression, then only endoscopic procedures or cystoperitoneal shunt is advised.
Okay. Your answer actually aid in the previous question itself. When you answered, you didn't apply your mind.
Yes.
Okay. You
Yes,
said,
sir.
what will you do? You said, sir, I'll put a shunt and watch the child. Most of the
Yes, sir.
times, the child settles down. The child does
Yes,
not
sir.
settle down and has a worsening hydrocephalus or a neurological deficit. Then I will plan for an additional procedure to decompress the cyst. You're right,
Yes,
bang
sir.
on. Same thing I expected you to answer here. Okay. So most
Yes,
of the
sir.
times, so is it a communicating hydrocephalus or a non-communicating hydrocephalus?
Yes, sir. Yes, sir.
Is this a communicating hydrocephalus? Is this a communicating hydrocephalus or a non-communicating hydrocephalus?
It is a non-communicating hydrocephalus. Since there is a obstruction of upper tract in Leishman Majestic, it is non-communicating, sir.
Okay, what is the definition of a communicating hydrocephalus as compared to non-communicating hydrocephalus?
Sir, communicating hydrocephalus, that CSF, there will be a blockage at the level of the arachnoid villi or the dural venous sinuses, where the obstruction of CSF will be blocked, where from choroid plexus to arachnoid villi, there will be a continuous flow of CSF will be there. In non-communicating, the obstruction either at the level of cerebral aqueduct or foramina montro or at the level of lateral ventricle or Magendie or Lusk. It is a non-communicating hydrocephalus.
In other words, you should the definition
Yes,
is
sir.
not right. If you say there is a communicating hydrocephalus is one where there is no block in the communication within the ventricular system. That is from
Yes.
lateral to the third ventricle to fourth ventricle resistance space. The obstruction
Yes,
may
sir.
be at a different level.
Yes,
Whereas
sir.
in a non-obstructive, the obstruction is not in any of these places. Murali, would you
Yes,
like
it
to
is.
add?
Nothing, sir. Nothing much. No.
Okay.
Yes, sir.
Okay. You put the shunt. Okay,
Yes,
and the
sir.
child does not
Yes.
benefit. I think we already discussed about the Y shunt and thecoperitoneal shunt and subarachnoid. The things, all those cyst excision can be attempted. Agreed.
Yes, sir.
Okay.
Yes, sir.
You put a shunt in this baby, or the child is already put in a shunt. Okay, in
Yes,
this
sir.
baby.
Yes, sir.
So, what all will you do to monitor the child? Or what is the advice you, okay, I'll take this child. This child is now post-days, post-operative. So when you're
Yes, sir.
discharging the baby, what are you going to
Yes, sir.
advise the parents?
Sir, I will advise the parents to monitor the head circumference weekly once in their home, and also I
They
will
will,
ask the parents. Yes, sir. Yes, sir.
Yeah, go
I
ahead.
will,
I'm listening. I will talk to you.
I will also ask to look for the if the to review the hospital if the child is having a refusal of fits or irritability, fever. If any complication arises, I will ask them to come to the hospital. And initially, to have the regular follow-up every month to the nearby hospital, I will ask. Sir.
Jaggu, what are the advice you will give the baby when the baby is getting discharged?
Sir, I agree with that. The features which present of raised ICT like vomitings or the rest of things which he had told, I agree with him. And I think head circumference, they cannot be apt to monitor.
Yeah,
I'll not advise head circumference monitoring, but
exactly. Head circumference is a clinical sign which has to be elicited by a healthcare worker. It cannot be done by the parents. Agreed. Next. You're saying something, Jaggu. Tell me.
yes, sir. Follow-up wise, maybe if they could able to come, maybe initial 1 year, 2 years, I would ask them to come for every third month or so.
Okay.
I look at the progression of the developmentally as well as the head circumference and the SOS. I plan for ultrasonography if needed.
Okay.
If the symptomatology is present, or otherwise I'll follow up the child after 2 years, maybe 1 to 2 years once I'll follow up. But I'll advise them to visit neurologist to further evaluation and the treatment policies which the neurology
Okay.
people will do, sir.
Good, Jagdish. You added a lot of things, but still you are missing a few things. When will be the first follow-up? Murali, you wanted to say something.
Yeah, Sridhar, you mentioned a very important finding on examination. No,
Yes,
that
sir.
makes an impact. I mean, in telling the parents when to report immediately. See, what is the common thing
Good
which
one.
you expect? Shunt malfunction, isn't it? So,
Yes, sir. Yes,
can
sir.
you tell the parents some telltale evidence, which says that shunt is not functioning properly? By looking at the child itself, parents can say whether the shunt is functioning or not functioning. You made that point in your examination. You specifically mentioned that in examination.
Sir,
I love it, Murali. Good one.
Yeah.
bulging anterior frontal, sir.
Yeah, exactly. You said the anterior fontanel is
Yes,
depressed
sir.
now, isn't it?
Yes, sir.
So
Yes,
the
sir. Yes,
moment
sir.
it starts filling up, that means the shunt is not
Yes.
functioning properly.
Yes, sir. Yes, sir.
So you have to explain
So,
these signs to
yes,
look
sir.
for.
Yes, sir. Yes.
That is when they have to report immediately. See, regular follow-up is something different.
Yes.
Okay, whereas reporting
Yes.
immediately in case of shunt malfunction is something different, because see, child can vomit for hundreds of reasons,
Yes, sir. Yes, sir.
isn't it? So added
Yes.
evidence makes more impact than individual evidence. Okay.
Yes. Yes, sir.
Okay. When is the first follow-up, Sridhar? You
Sir,
said 3 months, 6 months. Child is now 4th day
sir,
post-op. You're discharging the baby now. When will you discharge? When will you ask them to
sir,
come back?
child will discharge at this seventh day post-operatively. We'll ask to
Why
follow
7th day?
up
Why not
after.
earlier? Why 7th
Sir,
day? Why not earlier?
sir, we have a policy of giving antibiotics for 5 to 7 days, sir.
Okay, that's the next question I'm going to ask.
Post-operatively.
How long is antibiotics
Yes, sir.
mandatory for these babies?
Sir, if it is a congenital hydrocephalus with no signs of infection, we have protocol of giving antibiotic to 5 to 7 days, sir, post-patient injection.
Is it really needed? How do you classify
Sir, yes.
how do you classify the surgeries from necessity of antibiotics?
Sir, it is classified into clean case, clean contaminated dirty wounds. 4 classifications are
Lovely.
there.
So
Yes.
what category this falls into?
It falls into the clean case, sir. Clean
What is the
case.
antibiotic prophylactics for? What is the antibiotic recommendation for a clean case?
Sir, IV, the first generation
No, not the
cephalosporin,
type of
cephalosporin.
antibiotics. Not. I will come
Yes,
back to the
sir.
antibiotic choice. How long will you
Yes,
give
sir.
antibiotics in a clean case?
Sir, clean case recommended is there is no need for antibiotics, sir. But
Okay.
if they also, if any implant if any implant will put, they are suggesting one pre-operative antibiotic may be helpful if there is implant incision.
Perioperative antibiotics, I'll accept it. If it is
Pre-operative,
preoperative,
yes,
will
sir.
give. Maybe post-op, will give.
Peri,
Is it really
yes, sir.
required to give for 7 days?
Really, if the really it's not required, sir, for 7 days.
On a serious note, it is not required. However, it is a
Yes,
practice
sir.
of a lot of people. So perioperative
Yes,
antibiotics are mandatory. Why I'm saying if
yes,
it's
sir.
only prophylactic antibiotic, you can even start on oral antibiotics and discharge them sooner. Murali, can you justify why the policies of antibiotics for 7 days has come?
And we are not
Just
giving
because-
for 7 days actually, but we are following it for 5 days. 5 days is what we are following, sir. But I think it's
just to be extra cautious.
yeah,
No,
because
sir,
I think this
sorry.
policy came because initially we had a lot of shunt infections, if you remember, sir,
Okay.
in the
Okay.
previous years. So probably because of that, but off late it has reduced. Maybe we can
Okay.
even cut down on that also.
Okay.
Yes,
Ideally,
sir.
the
Yes, sir.
perioperative antibiotics are sufficient, but
Yes,
because there's a shunt and because we don't want a meningitis and a problem, unit prefers to give 5 days as a personal preference. It's not
Yes, sir.
what do you call it? It's not a mandatory thing. Okay.
Yes,
What is
sir.
the choice
Yes,
of
sir.
antibiotics? What is the choice of antibiotics?
Sir, third generation cephalosporin and go for injection ceftriaxone will give, sir. Along with injection the aminoglycoside, like injection amikacin we can give, sir. Will give.
What is the advantage of giving aminoglycoside? What is the drawback of giving aminoglycoside?
Sir, aminoglycoside will have the better blood-brain penetration and it will be effective against the
Sure.
gram-negative organism.
Sure.
Yeah.
If I had attended
I will
deeper
check.
studies class, you would have answered it. Jagu? Jagu?
Sir, yes, sir.
Tell me, is aminoglycoside, what is the advantage? They said, why do you give aminoglycoside?
Sir, it will
Does
cover.
aminoglycoside cross the blood-brain barrier?
Aminoglycoside actually.
Aminoglycosides don't cross the blood-brain barrier unless it is inflamed. Okay. And in case there's a meningitis, in fact, when Pratik discussed the other day, this is what we discussed, saying that aminoglycosides are not, and even ceftriaxone is something he said. One more medicine, I don't remember. Anybody please remind me.
Yes, sir.
That don't, yeah,
Piperacillin tazobactam.
which one?
Piperacillin tazobactam. It also crosses
Okay.
when the meninges are inflamed. Otherwise, the blood-brain barrier crossing percentage is 30%.
Yeah. So piperacillin tazobactam and aminoglycosides do not cross the blood-brain barrier unless it is inflamed. One set of argument which used to be given earlier is, yeah, it is necessary only if there is a infection, that means meningitis, so we don't give, otherwise it is all right. But the counter to
Yes,
that
sir.
is, the moment inflammation comes on, it doesn't cross. Okay.
Yes, sir.
So
Yes,
in this case, even though it is a CNS case, what is the rationale of giving aminoglycosides? Jagu?
If
Okay, I will tell my rationale. Then Murali and Ramachandra sir can add to what I have said, whether they are right or wrong. Actually speaking, aminoglycosides are not indicated. Perhaps
Yes,
the
sir.
only reason why we use is to avoid a possible contamination during surgery. Okay, because intraoperative infections are because of handling of other things, not necessarily meningitis. So we are not trying to
Yes,
treat
sir.
meningitis, but these are prophylactic antibiotics to prevent infection because of handling. That perhaps can
Yes, sir.
explain why aminoglycoside may be helpful. Murali and Ramachandra sir, please add, please.
100% correct, because you're doing a subcutaneous tunnel, you're handling the skin more. So skin is usually colonized by gram-positive organisms, isn't it? So for
Yes,
that,
sir.
any
Yes.
ceftriaxone, the cephalosporin should be good enough.
Yes,
So
sir.
aminoglycoside, which is active more against gram-negative bacteria, so
Yes, sir.
not really indicated, as said, as an additional precaution
Yes, sir.
to prevent infection.
Yes,
And
sir.
it doesn't attain good levels in CSF. So it's not for CSF penetration, not for
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Can I add a
Thank you,
point,
Murali.
sir?
Ramachandra sir?
Can I?
Yes, please.
No,
Can I
Gauri,
add a
Gauri
point?
wanted to.
Hey, welcome, Gauri. I didn't see you. Please.
Oh,
Add,
sorry.
please.
The aminoglycoside, as you said, the E. coli has a propensity to stick onto the surface. That's what, as it happens in bladder or anything. And
Okay.
same thing with the shunt. So sticking of the bacteria to the shunt. So
Okay.
that's when you dip that in, use gentamicin solution as a precaution. Something like antibody impregnated this thing. So
Yes.
it is to prevent during the procedural contamination rather than subsequent ones, as you said, yes. Because
Lovely.
because to prevent E. coli sticking onto the forming a surface this thing on the shunt or
To
internally.
prevent colonization of the any implants, it's preferred to give a good wide spectrum antibiotics, both which covers both gram positive and gram negative, because contaminant can come in any shape. Agreed. Ramachandra sir, anything, or shall we go ahead?
Aminoglycoside does not enter CSF, period. So not given
Okay.
for anything, any indication.
Okay, sir. Fine, accepted. So this basically is what I'm saying, Sridhar, is that it is not about your practice. You should be able to justify why you're doing. That's all. Once you know the rationale and then give, it's fine. Because if you look at it, all of us have agreed that aminoglycosides do not cross the CSF barrier. However, each one practice is different and they have got a different justification. It's okay as long as you are clear in your mind. All right. Okay. Okay. Now that
Yes.
next other thing I wanted
Sir, I
to ask
have
you
a question.
particularly, please.
Sir, few things I have seen in BMC. Sir particularly says only one shot antibiotic just before giving the incision, even for a process like V patient which you are placing. And for clean cases, like simple procedure where we are not touching the bowel or these things like ureteric system or some urological system, they are not advising antibiotic as a routine thing since it is a clean thing.
Correct. That's what I told in the beginning. That's the ideal thing that should be practiced. I'll tell you what. Sometimes it's evidence-based medicine. It's sometimes emotion-based medicine. Okay. For example, a case of like Murali said, we have tried not giving antibiotics, but sometimes if there is a shunt-related infection, the cost for everybody, the patient, the hospital, the society, is much higher. So that's the reason for which, as a unit protocol, we have increased the antibiotics, perhaps because of to cover inadvertent breaches in the sterilization protocols. Okay, it's not the right thing, but it's a sort of department decision being done. All right. So sometimes it's not just a rationale. We died. For example, herniatomies, time immemorial. For the last 22 or 23 years, we are not given antibiotics for herniatomy, even when the stage when we are just putting on a gloves and operating without even washing the hands. Okay, that was being done when the numbers are small and we are doing. Gauri must have seen a lot of them being done earlier. However, we have changed the policy of at least scrubbing for the case and putting on gloves and go and do it, but still no antibiotics. The incidence of infection amongst the herniatomies in our hospital, to the best of my knowledge, is not more than 10 in the entire career. Okay, so far. So we have been able to handle the grip there because the less number of people, more disciplined hand movements. However, in shunt, because of the painful realization there's a lot of infection, and because there are so many people, we have started giving antibiotics for a longer period, but not justified. All right.
Yes, sir.
Next question I wanted to ask you, Sridhar, is I don't know.
Yes,
At least I was in the habit of teaching the parents to pump the shunt before discharging them, especially if you're using a Chabra shunt. I understand
Yes,
if you
sir.
put the other type of shunt, maybe it's pumping may not be easy. But as a policy,
Yes,
we used
sir.
to teach them how to press it. And I used to
Yes, sir.
explain to them to come back if it is malfunctioning. Do you still do
Yes,
that
sir.
or don't do that? You do that or you don't do that?
Sir, pumping we are doing. So we will advise them to pump if to check for the compressibility of the chamber. We are advising.
Okay. So it's if you're told in the examination, it would have been good. Okay. When
Yes, sir.
I'm
Yes, sir.
simple question, how do you check
Yes,
the
sir.
patents of the shunt by pressing? We're talking about Chabra shunt. Then we'll
Yes,
come to
sir.
other types of shunt.
Yes,
In a
sir.
Chabra
If
shunt, how will you identify the functionality of the kit?
sir, while pressing itself, if it is very difficult and is non-compressible, there is a probably the site of obstruction will be the distal. But it
Very
is
good.
compressible. But while the refilling doesn't occur, or if it is refilling is very slow, then there is a chance of obstruction will be the proximal ventricular end, sir.
Okay. Is there anything
Yes,
which
sir.
can add? But this is what generally we do. Is there anything
Yes,
else
sir.
you can note to confirm that this functioning is all right?
Sir,
Apart from this?
we can tap the chamber with the hypodermic needle, sir.
No, 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 no. Functioning, how will you know?
So in hyper, if you are able to aspirate this, yes,
No, 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 no.
sir. Yes,
Okay, other thing ideally is apart from what I said, when you press it, if it is
yes,
blocked,
sir.
you will see that it's perhaps the distal end is blocked, then it will not be able to compress it.
Yes, sir.
On the other hand, once it is compressed, but it's not filling from above,
Yes, sir.
it indicates that the proximal end is blocked. In addition,
Yes, sir.
previously what people used to say is you block the compressible part of the shunt above the chamber, well above the chamber, and check it. It's just like your harvest test for identifying the flow of direction in the veins. Okay,
Yes,
if you
sir.
block
Yes,
it
sir.
and you press it, you will not be able to fill it up. The moment you release, proximally it will again fills up, means proximally it is patent. This is just theoretical advantage to know about it. All right.
Yes, sir.
So you're
Yes,
going to teach
yes,
the
sir.
parents how to do shunt
Yes, sir.
and then come back.
Yes, sir.
And then,
Yes, sir.
what are the things will you check for when the child comes for your first follow-up?
I will assess the general condition of the patient. I will check for head circumference and
Mr. Fall down in the first.
anterofrontal.
One second. Do you
Yes, sir.
expect the head circumference to fall down in the first visit itself?
Sir, not fall down, but as a part of examination, I will check, sir.
Okay,
Each
as a
and every
part
visit,
or
I will
as
check.
a baseline, fine. So, but what is more
Baseline,
important to see?
I will check for the anterofrontals and the general condition of the child, and also the
Okay.
anterofrontals.
So one, you're going to look for center of the
Anterofrontals
function. Fine. One by means of the anterior frontal, head circumference, and what else?
and activity of the child.
Okay. Apart from that, we
From
discuss all
them,
this.
I will check the. Yes, sir.
You will check for the.
The shunt patency.
Very good. You will check for the shunt
Yes, sir.
patency.
Shunt patency.
Then what
Yes,
else
sir.
were you going to look for in the first visit? I'm very clear about first visit.
Sir, suture line, if there is a suture line is intact or associated,
Okay.
if any.
Okay.
Yes, sir.
You would also look for any infective complications, in the sense
Infective
any
complication.
cellulitis,
Yes.
any shunt tract
Yes, sir.
infections you got to look for.
Yes, sir.
Then you look
Yes,
for
sir.
any acute complications. What are the acute complications you expect in a hydrocephalus? What are the chronic complications?
Sir, post-VP shunt, an acute complication like infection, shunt malfunction, intraventricular hemorrhage, or a wound infection. These are the acute complication methods, sir.
Okay.
Chronic
How will you
complication.
So how
Yes,
will you
sir.
identify each one of them clinically
Sir,
and investigation?
yes, sir. Sir, wound infections can be identified clinically, sir. If it
Okay.
is
By?
a shunt malfunction, it can be
How will you
identified.
identify
There is
wound infection? Infective
sir,
complications, how will you identify?
there will be the redness at the suture site, and there is a
Okay.
serious discharge or first discharge will be there. And
Not
there is
always say, don't
redness
say will be
present.
there. May be there.
Yes, sir,
Okay.
may be there. And
That much?
redness along the shunt tract may be there.
Oh, quite. Okay. Tell me.
Yes, sir. Redness along the shunt tract,
Okay.
distal catheter tract may be there.
Okay.
Infection.
Is it
Yes,
possible
sir.
that the child does not have infection? That is, there is no
Yes, sir.
redness either on the
Yes,
shunt
sir.
tract or on the wounds, any of the wounds, but you still see a diffuse fluid around the shunt. So what does it indicate?
Yes. Sir,
There is a
diffuse.
extravasation.
Yes, sir. Yes,
There is
sir.
a fluid around
It is
the shunt tube.
yes, sir. It may be a catheter seepage of the CSF will be there. It
So what does it indicate?
indirectly implies the shunt malfunction since the
One,
shunt is not draining the CSF will be there. And
understand. Agreed.
second, if you make the hole in the meninges very large, there will be a
Okay.
periventricular seepage of CSF will be there.
Okay.
And,
Anything else?
yes, sir.
Anything else? For example, you've seen, Sridhar, you're a good surgeon. You have made a small burr. You have made a small
Yes,
hole
sir.
in the dura, not much. It
Yes,
is snugly fitting
yes,
in.
sir.
You put in a
Yes,
shunt.
sir.
Shunt is still shunt is functioning, and you still find
Yes,
a
sir.
lot of amount of seepage around the shunt. What does it indicate?
Yes. Sir, shunt is function. It may be a reactive edema around the VP shunt,
Jagu?
sir.
Okay, agreed. That is generally around the shunt tube, shunt chamber, because you dissect the
Yes, sir.
space around it. But generally
Yes,
around
sir.
the
Yes,
shunt
sir.
track, you don't get it. Jagu?
Yes, sir.
The three possibilities, as he said, one is malfunctioning and peritubal leakage, one thing, and making of dura very large opening, and third
Okay.
possibility, break in the connectivities, like
Shunt
approximately
fractures.
dislodges from, yes, sir, shunt
Shunt
fractures.
fracture, so shunt slipping out. Apart from that,
Yes, sir.
sometimes the hydrocephalus is severe and you put in a high pressure shunt. Okay. So
Yes, sir.
the hydrocephalus may not be adequately decompressing, so the CSF may be seeping by the side. Okay.
Yes, sir. Yes,
You
sir.
have to think of all the things.
Yes, sir.
Okay. In a shunt,
Yes,
there
sir.
are we talked about high pressure and a low pressure shunt. Okay.
Yes, sir.
So
Yes,
how many
sir.
valves does the Chabra shunt have, and which is the
Yes,
one which
sir.
determines whether it's a high pressure, low pressure, or medium pressure?
Sir, there are two valves in the Chabra shunt. One is the Pauline spring valve, another one is the slit valve. And
Very good.
it is the ball in the spring will determine the medium pressure or low pressure sensor.
Are you sure? What about Jagu? He says the spring valve determines the pressure.
Oh, sorry. Sorry.
Sir, distal and slit valve, sir.
Sridhar?
Sir, sorry, sir. I will change it. The slit valve at the distal catheter will determine the medium pressure and low pressure.
Yeah.
Yes, sir. Yes, sir.
Okay, so it's a distal end which determines whether it's medium pressure, low pressure, high pressure. Generally, what do you
Yes.
prefer?
Sridhar,
Yeah.
how do you choose low or what is the rationale between this? Sir is asking low pressure, medium pressure, high pressure. What is the rationale for them?
Sir, if the child is a neonate or a child will be a neonate or less than 1 month, 2 months, child will be lying position, then we will choose for low pressure shunt. But if the child started in sitting position, at that time better will use the medium pressure shunt to prevent the excessive draining of CSF, sir.
No, that is a very lucid answer, but there is a scientific reason to that, which we don't do. How do you determine on table? There are methods. If you have seen
Thanks, Gauri.
Lemans people coming and doing
Yeah.
it, or if
Yes,
you
sir.
are assist a neurosurgeon doing it, you would know. They do some measurement and then they put it. So
Sridhar,
there is
I
not
told you
like,
this, no?
yeah.
Sir, pressure will be monitored on table.
Yes.
On table, we can. So that based on the pressure, we can choose it, sir.
How do you measure the pressure? How do you measure pressure?
Sir, by checking the millimeter of H2O level, sir.
How? Tell me.
We
So you
will-
connect the BP manometer, is it?
Oh man, there
Not
is no
manometer,
H2O
sir.
there.
Sir, we will
Tell me.
connect with the. We will connect with the. We'll connect with the saline with the tube and to check the level of the saline from the.
How will you do that? How will you connect that? See, like if for a central venous pressure monitoring, you were saying that water manometer, or a saline manometer with tubing. Agree.
Yes, sir.
But how do you connect it inside the brain?
Sir, to the ventricular catheter in.
So what is ideally recommended, Sridhar? So basically, they do an LP before the procedure. In the patient in the lateral position, now with the view caudal, no? Same position, they do an LP that is connected to the manometer. So then you measure the pressure based on that. How do you say low pressure, medium pressure, high pressure? Is there any very cutoffs or something? It is just arbitrary.
No, low
What
pressure is
is up to
20 to 40 millimeter of H2O is low pressure, sir. 40 to 70 mm H2O is the medium pressure. 100 to 170 mm H2O is high pressure, sir.
check up again. You have to check up again. It starts from 0.
Okay, sir. Okay.
If I'm
See, frankly, I don't know the pressure variations about low, medium, or high.
0 to 10,
Yes, sir.
10 to 20, then above 20 or sometimes above 40, some centers consider high pressure. So 0 up to 0, 0 to 10.
No, that is millimeter of mercury, sir. I am telling millimeter of H2O.
Centimeter of H2.
Okay, can we
Not millimeter, generally it's centimeter water.
Centimeter of water.
Centimeter of water.
Yeah.
Okay, sorry.
Yes, sir. Yes, sir. Yes, sir.
To check it. Other thing I
Yes,
wanted
sir.
to ask you is LP indicated or contraindicated in the presence of hydrocephalus? What is the danger?
Sir, LP is contraindicated because LP in the setting of hydrocephalus leads to coning of the brain, sir. That is herniation of the contents of the brain through the foramen magnum will cause compression in the brain stem.
Agreed.
It leads to respiratory failure, sir. Yes, sir.
Fantastic.
Yes,
But
yes,
Gauri is saying
yes,
Gauri can become. Gauri is not an ordinary man. He's a well-read man. So what is his rationale of doing an LP for finding out the pressure?
Sir, here we are checking only pressure. We are not removing the CSF, sir. So the lot of
Excellent.
CSF won't be there.
We are not
Yes,
draining any CSF. It is just meant for pressure.
Yes, sir.
Okay.
Yes,
What
sir.
is the other
Yes,
method?
sir.
For example, I am putting it measuring a pressure in the spinal
Yes, sir.
canal is in the
Yes, sir.
extradural space. Is it going to be reflective of the pressure inside the brain in an obstructive hydrocephalus?
Sir, no, sir. Measuring the pressure in the subarachnoid extradural space in the obstructive hydrocephalus, it doesn't show the values.
It may or may not reflect, but it's a practice being done. What is the other method to identify the pressure inside the ventricle?
Sir, we can measure the pressure by tapping the anterior frontal, sir.
Okay, I'll put it this way. During the procedure itself, once you do a burr hole, there is a ventricular cannula There's a measurement
Yes.
ventricular needle. Okay.
Yes, sir.
Then there's a marking of cannula,
Yes, sir.
which is basically a broad, hollow
sir.
needle, blunt tipped.
Yes.
Okay. You put it inside the brain, and you can connect
Yes,
it to
sir.
water manometer to pressure it. However, we don't routinely
Yes,
do
sir.
it. Murali was wanting to say something.
Yes, sir.
Nothing, sir. Nothing.
Sir,
Gauri?
I am saying recessive index, sir. What is the value of recessive index? RI.
RI,
Yes, Gauri?
you're better do with a ophthalmic scan and see the pressures around the optic nerve rather than recessive index. I don't think it is. It is just it was for some time, like as with kidney and other
Yeah.
also in undescent testis. I think it is just to know it. I don't think it's had much benefit over.
Very true.
You're better off doing an B scan over the globe and what the ophthalmologists do. So that would be more indicative because it directly shows the pressure on the optic nerve. That would show monitoring as if you're using that as a pre-operative or post-operative one rather than recessive index. It's very subjective and not of much use.
Yeah, it's better to know about it. It's better to know about it. So that's how you do. Okay. Okay, raised pressure, he said. Are is the other indirect evidence of severe hydrocephalus on imaging?
Sir, imaging. Yes, sir. Sir, if there is a presence of atrophy of the white matter, or a presence
apart from
of
that, what earlier than that? Periventricular?
seepage of the self with the presence of foreign cephalic cyst. These are the indication of high pressure, sir.
Three things. One is periventricular seepage. So you can see that the fluid is seeping into the what you call brain substance, periventricular.
Yes, sir.
Number two, if there is a sort of pouring, you can see that there's too much of CSF around the brain matter. The brain matter gets compressed, and then effacing of the sulci. Okay, the sulci get effaced.
Yes, sir.
CT scan or an MRI that can suggest.
Yes, sir.
Of course, other things that you suggested. Okay.
Yes, sir. Yes, sir.
Okay. The reason some neurosurgeons have a habit of cutting off the lower end. Okay. If you do that, what will happen?
Sir, if we cut the lower end, if a medium pressure shunt will become a low pressure shunt, sir.
Low pressure shunt?
A medium pressure shunt will lead to low pressure shunt will go to excessive drainage of CSF may occur in the post-operative, sir.
Alternatively, it will form a no pressure shunt, not a low. It's a no pressure.
Exactly. No pressure.
No resistance.
No pressure.
You cut off the valve, no?
Yes, sir. Yes, sir.
Now that if you say the distal valve is more important, what is the purpose of the spring valve in the VP shunt? Why is there one more valve?
It is act as a one-way flow of the CSF, sir.
Excellent, Sridhar. I am very, very impressed with the way you are answering today. It makes sure that it is going to be one-way flow. So it is preventing it from going. Okay, very good, very good, very good. What are the different types of VP shunts that you know?
Sir, there are three types, sir. One is differential pressure, fixed differential pressure shunt, flow regulated shunt, programmable differential pressure shunt, sir.
What is the second one you said?
Flow regulated shunt, sir.
Okay, okay.
Here,
I'm not very strong in this, so Murali and Gauri should take over the question.
Yeah, that is the way one as you said for defining the mechanism. Any other way to describe the mechanism of function of the valves? That is the little older classification. This is the new
based on the valve.
I agree. Based on the valve, do you have anything?
Yes, sir. Based on the valve, there are four types of
like what you have.
Yes, sir. Sir, based on the valve, there are four types, sir. One is a ball in spring valve. Second is slit valve. Third one is mitten valve. Fourth is diaphragmatic valve, sir. There are four types of valves are there.
Yeah.
In Chabra shunt, the diaphragmatic valve and slit valve both are combined in Chabra shunt, sir.
Yeah, both.
Yes, sir.
No, spring valve and slit valve, no? Not a diaphragm. Chabra.
Oh, yes, sir. Yes, sir.
Yes, sir. Spring and slit.
Spring and slit, sir. Yes, sir.
Where does the diaphragm comes? Yeah, please go ahead. Go ahead.
No, what is the if you're following this child up within say 2-3 months, 4 months, or 6 months, the mother says the child has there is a sudden deterioration in his milestone or is listless or irritable. Then when you examine, he has the Yes, collapsed ventricle. So how do you manage that? He says ventricle is normal, it's not dilated or it's collapsed. What is what's
If
happening?
it is collapsed ventricle, I will get an ultrasonography to look for the. If it is a lateral ventricular collapse, there is a possibility of split ventricular syndrome, sir. It is occurs because of the over drainage of CSF into the VP shunt. So what drainage of CSF? So initially the child is managed with a symptomatic treatment. If it is child is more symptomatic, I will go for changing the shunt, which I will prefer high pressure shunt in case of slit valve syndrome, sir. Yes, sir.
So this comes to your question, like you mentioned about the flow regulated and the pressure
sir.
control. So how do they work? How does it work?
Sir, flow regulated shunt will work as three phases, sir. Initially, if the pressure is low, it will act as a flow is directly proportional to the pressure of the ventricle. But once the pressure is raised in the medium level, the flow will be constant in spite of rising the pressure, sir, so that there won't be any excessive range of CSF. But while the pressure become very high, it will convert it into a flow is directly proportional to the pressure to prevent the hypertension of the CSF, sir. Where a programmable shunt, where we can manually change the pressure control with the help of the devices, sir.
Sir,
We can change the program to low pressure to medium pressure or to high pressure.
only
Yes,
few
it's
minutes.
magnetic. You switch. Yeah.
Yes, sir.
Bedwetting alarm on. So always have a way to come over. Whether it is Zoom meeting or this thing will stop and reconvene anyway. I don't think the world can control Indians anyway.
Yeah, that is true.
Yes, sir.
Okay. Sorry, your answer. Gauri was asking you something.
Yes, sir.
Gauri or Murali?
No, sir. He's fine.
Yes,
He's perfectly right. He just
Yes, sir.
explained the whole mechanisms. So that's why you have the additional advantage compared to Chapter, where the child starts growing from a
Yes, sir.
newborn to infant, older age group, where you can use the magnetic controlled either the flow or the device controlled shunts. So as
Yes,
to
sir.
not to change the shunt when something like this happens. Yes.
Yes, sir.
Yeah. Thanks. Thanks, Sridhar.
Okay.
Yes, sir.
Now, since Gauri made a mention and you also made a mention of slit ventricle syndrome, what exactly
Yes,
is
sir.
slit ventricle syndrome? How do you diagnose? How to handle? And what are the challenges?
Sir, slit ventricle syndrome is occurs due to the over drainage of CSF from the lateral ventricle, sir. If the child
Okay.
presents the symptoms, most of the slit ventricle syndrome will be asymptomatic. Where
No, once again.
20
If there is over drainage, why does it lead to
Yes,
hydrocephalus
sir.
at all? It is over drainage. Agreed. So once it is over drainage, actually it should be causing less amount of pressure, no? So why does it lead to hydrocephalus?
Sir, but to maintain will be a normal pressure of CSF should be maintained, sir. But here the pressure will go less than normal value, where ventricles get collapsed.
There's something important about the
So
slit
what is the
ventricle.
normal pressure of CSF? That's the sir is coming to that. So what is the normal pressure for functioning of the brain?
So there is some of CSF, sir. Of the ventricular end of the catheter, sir. Because of the obstruction, it will block the flow of CSF from the ventricular end of the catheter. And yes, sir.
Yeah.
Hello.
Continue.
Sir, and most of the slit ventricular syndrome child is asymptomatic, where
No, sir.
10 to
What's the normal
20% child
pressure?
will present features
What's
of
the normal?
normal pressure of normal pressure is 10 to 25 millimeter mercury.
It's quite high, no? 25 is quite high, isn't it?
Sir, 10
Yeah.
to 15, 10 to 15.
You see, you are doing in
10
water,
to
and then
15, sir.
sometimes
Yes,
you are
sir.
measuring in water,
But-
sometimes in mercury. You will lead to your confusion to yourself. So stick to one metric.
Yes.
Oh, yes, sir. Yes, sir. Yes, sir. Yes, sir. Sir,
Yeah, Sridhar, continue.
sir, Syndrome is sir. Okay. Syndrome. The clinical features mostly children with Slit syndrome are asymptomatic. 10 to 20% will present with symptoms such as headache, lethargy, drowsiness. Sir. Intermittent headache will be the clinical feature of the Slit ventricle syndrome. So investigation by doing ultrasonography or MRI CT which shows the collapsed lateral ventricles will be seen, sir. And management is as conservative, but even the conservative, it is not curable. Then we need to change the high pressure shunt, or to increase. In case of programmable shunt, we need to increase the pressure control of the shunt. Sir.
Okay.
Yes, sir.
Sir, hello.
Yeah, Jagdish.
Sir, I think his pathology missed out, sir. Though ventricle looks small, the ICT will be raised, sir. Because the excessive drainage will induce the gliosis of the brain parenchyma, that will lose the compliance of the ventricle system or the parenchyma of the brain. Over a period of time, that will act as a fixed volume brain ventricles.
Fixed volume ventricle, yeah.
Yes, sir.
Yes, sir.
So that will lead into the even small quantity of the fluid which
CSF,
contains inside. That will cause a raised pressure. So basically, it is the excessive drainage inducing gliosis and loss of compliance of the brain parenchyma that will cause the Slit ventricle syndrome, sir.
Yes. That is a chronic version of it, and yes, it's a very difficult one to treat. It's a chronic version of it. What Sridhar is telling is not acute and most asymptomatic ones where you can identify early. If you don't identify early, yes, what you said is a chronic version of it, and that's a difficult.
Okay, sir.
Yes, sir.
That's a separate.
Yes, sir. Yes, sir. Yes, sir.
And many times these symptoms can be postural in variation. In the sense, depends when the child is supine, he may be symptom free, and when there is gravity assisted drainage also. Okay,
Yes,
when
sir.
the child is sitting or erect, then his symptoms will be aggravated because there is more CSF drainage.
Yes, sir.
Jago, brilliant, very nicely put. In fact, I wanted to highlight the same. That is the question I was starting. So, slit ventricle syndrome, and clinically, as I said, it will show features of raised ICT. Ultrasound,
Yes,
if
sir.
it is ultrasound in a smaller child, or maybe a CT scan may show a normal or a narrow ventricle. Okay,
Yes,
but
sir.
how will you pick it up? How will you diagnose?
Sir, we can able to see the signs of intracranial hypertension, like
Okay.
the child will have clinical features of headache, dizziness, everything. On optical examination, there will be a papilloedema may be present, papilloedema, and
Okay.
and the presence of sunset sign and irritability and bradycardia. These are the signs we can pick up to look for the increased intracranial hypertension.
Okay. Now that you're talking about raised clinical features of raised intracranial tension, what are
Yes,
the
sir.
general clinical features of acute increased intracranial tension and chronic raised intracranial tension?
Sir, in acute condition, there will be antifrontal bulging,
If the
and
child is small,
if the child is
for the
small,
child it
sir.
does not. Apart from that,
Yes, sir.
clinical, what are the symptoms? What are the signs?
Symptoms: the child will have headache, vomiting, refusal of feeds. In
Okay,
case of
vomiting. What is so
infertility,
special about the vomiting? What is the speciality of this vomiting?
this will be a non-projectile vomiting, sir.
Generally it will be early morning vomiting.
Early morning
Early
vomiting.
morning
Yes,
vomiting.
sir.
And headache may be there. In small child, how will you identify headache? Because a child may be 8 months, 1 year, the child will not be able to tell you headache.
Yes, sir.
How will you identify?
Sir, child will be have excessive crying and
One.
refusal to feeds will be there, sir.
Apart from that,
Refusal to
anything to
feeds.
suggest headache? Okay, some children do have head banging. They just bang their head on
Head bang.
something. So that may be
Yes,
an
sir.
indication the child may have headache. Okay, apart from that?
Yes, sir.
So, yeah, tell me, Sridhar, Murali.
Nothing, sir. I didn't do anything.
Okay. So clinically, one, vomiting, headache, anything else history-wise? Acute raised ICT.
Respiratory vomiting, headache.
May have blurring of vision,
Yes, sir.
diplopia.
Blurring of vision, diplopia will be there, sir.
Okay.
And yes,
Always stop using that will be there. We always replace it with saying may be there.
Maybe
Okay,
there.
may
Yes,
be
sir.
there, may not
Yes,
be
sir.
there. Okay, these
Yes,
are
sir.
symptoms which a patient may present. Vomiting, non-projectile, early morning vomiting. Okay. So
Yes,
what are
sir.
the clinical
Yes, sir.
features of raised ICT that you can see in these children?
What is Cushing's
Sir,
reflex?
What is Cushing?
sir,
Cushing's
Cushing
reflex.
reflex, because of the during increased intracranial tension, there will be a bradycardia. There will be a bradycardia. Will be there, sir.
Sir, I don't know the answer, sir. Please clarify, sir. Even I don't know the answer of what is Cushing's reflex.
Bradycardia and hypertension.
And hypotension. Yeah.
And
Hypotension.
Hypertension.
Systemic hypertension and bradycardia will be there, sir.
Yes, yes. That is Cushing's
Yes,
reflex.
sir. Yes, sir.
It is sign
So
of
what is-
acute sign of raised intracranial.
Right. Yes, sir.
Okay, so apart from Cushing's reflex, what else will be there?
Sir, there will be a neck rigidity will be there.
Neck
And,
rigidity is a sign of meningitis, to the best of my knowledge, not about raised ICT. Am I right?
No,
Yes, sir.
sometimes raised ICT also.
I don't know. I don't know.
Is it not? I'm not sure. No, I don't think so.
I don't think so. In a cross check.
I will check it, sir. And
Anyway, Vandana or Vinupriya are supposed to be checking out in the textbook of Nelson. Who is there in the room? Ask them to check in the Nelson right now. Before we finish the class, we can get. Okay, go ahead. Go ahead.
And the sunset sign will be there. Downward gaze of eyes will
and
be,
inward
and
gaze.
downward and inward gaze of the eyes will be there. And
Will be there,
optical-
maybe there.
maybe there. And fundal examination will show papilloedema.
Okay. Apart from that, if the AF is present, it will be bulging. And
It
what is
will be
crackpot
bulging,
sign? Somebody checked what is McEwan sign? Somebody checked it? Vandana, Vinu?
Yes,
Okay.
sir.
Yeah, what is McEwan sign?
Sir, in case of hydrocephalus, they tap the skull near the junction of the frontal, temporal, and parietal bones. Because
Okay.
of the hydrocephalus and separation of the bones, they hear a noise like when they crack a pot. That kind
Okay.
of sound they hear.
They put a needle, is it?
No, sir, they just
Tap.
tap.
Tap. Okay. Tap means okay.
Tap
Okay. Physical tap. Okay.
Physical
Okay.
tapping.
I thought it's a needle tap. Okay. Sorry. Okay.
No.
You're right. Okay. So you get a crackpot sound. That is McEwan sign.
Yes.
Yes, sir.
Okay. And for AF has to be fused or open. Either way, it doesn't matter.
Open. Open.
If
Okay.
The sutures will be
AF.
separated.
Okay.
All the sutures will be separated because of excess CSF accumulation.
Okay. I think
Basically,
yes,
it is a taleburde. Okay.
sir.
So taleburde, when it is intact, you will get a Gattam sign.
Okay.
When the taleburde is broken into multiple bones, you will get a McEwan sign. Okay. So basically, think of Carnatic music where they play Gattam. When the Gattam is
Good one, sir.
intact, it will be music. If Gattam is not intact, it will become McEwan sign.
Good one. I think I got confused with the silver beaten appearance on the X-ray. Okay, if the fortinels are, if the sutures are fused, because of the raised ACT, there will be sort of silver beaten appearance on the X-ray skull. I think for that you require fused fortinels. Check it and tell me. Anyway, thanks. Thank you very much, Vandana. Okay, next.
Sir, Ramesh sir, that is correct, sir. Actually, those silver beaten wire appearance and all those things will be seen once the fontanelle are fused, sir, so that will exert the pressure
The
over
calvarium.
the
Calvarium.
yes, sir. So that gives the appearance of that wire sort of thing, sir. Whereas in unfused skull, it is not visible, sir. Unfused skull, McEwan sign is the sign of raised ICT.
Okay, good. So these are the clinical features that you see, elicit, papilledema and fundal examination. What are the clinical features of chronic raised ICT?
Sir,
For
there will
example,
be
you put in a shunt, you put in a shunt, child is all right for 3 years, then they come back.
Yes, sir.
Okay, so every yearly follow-up, what are you going to check for?
I will check for the milestone development, sir, and IQ development, and so
what are the clinical features of chronic raised ICT?
Sir,
So there may be delay in the developmental milestones or
milestones. Low
or
IQ. Low IQ.
no, or in the milestones itself, there can be regression of attained milestones.
Yes, sir. Yes, sir.
Okay, these two things can suggest that can be a late onset block shunt or something. Hydrocephalus is increasing. Raised ICT.
Yes, sir.
Anything else?
Yes, sir. And the child may have the chronic headache.
Chronic headache.
And visual disturbances also may be there.
Visual disturbances. Okay.
Yes, sir. And
what are the other subtle features? In fact, there's one thing I invariably ask the children when they come to me. That will give a general indication that the shunt is functioning or not. Scholastic performance. If the parents say there's a reduction in scholastic performance, that is, the child was doing very well earlier, now the child is not doing that well, he is dropping in his marks, then it may indicate that there may be chronic subtle hydrocephalus. Okay?
Yes, sir. Yes, sir.
And then, anything else? You heard what is cocktail type of personality?
Cocktail type of.
Okay. You see in cocktails, what do? Okay. Jagu, Vandana, tell how Sridhar behaves during a party.
Sir, I have not heard that words which you are saying.
That's why I'm telling you. I'm telling you, no problem. I will tell you now. Don't worry. Okay. Just imagine Sridhar. When he is drunk, you have seen Sridhar, no? He doesn't listen. He keeps on talking.
Okay, sir.
Okay. That's a typical cocktail personality. Not listening, just talking all the time. Okay.
Yes, sir.
Cocktail personality.
Okay. All of us do have, including me, but sometimes it's more exaggerated. Okay. So these are the general subtle signs to say that the child may have raised ICT or may have a block. Yeah.
Yes.
Murali is saying something?
Nothing, sir. Nothing.
Okay. Okay. So these are things. Now, last few questions before we wind up about what are the complications of BP shunting and how do you manage each one of them?
Sir, complication will be early complication, late complication, sir. Early complication will be infection. Second one is intraventricular hemorrhage. Third, shunt misposition, shunt malfunction. So infection we can manage with antibiotics and dressings. The intraventricular hemorrhage we will observe, sir. We will observe mostly.
No.
In case
if there is infection, you didn't stop there. You may give antibiotics as a minor infection. But what happens if there is a colonization?
If there is colonization, we need to replace the shunt, sir. Or we will convert the patient into external drainage.
No. Don't jump.
Yes, sir.
Okay.
Yes, sir.
You get
Yes,
into
sir.
more problems. If the child has got a minor shunt tract infection, you can give antibiotics and wait. However, if there is any clinical features of meningitis or an infected tract which is not responding to antibiotic, you will have a very low threshold to remove the shunt.
Yes, sir.
Because it is impossible to sterilize an implant in the presence of an infection. Because there will always be a colonization. But as long as you give antibiotic, it will be settled. The moment you take it, it will flare back again. So it is always worthwhile, and it is far more cheaper to remove a shunt and put back than to keep on persisting with antibiotics not working and then coming to put it very late. One.
Yes, sir.
However, after you remove the shunt, it depends on whether the child is shunt dependent or not. If the child is shunt dependent and cannot manage without a shunt, then you can think of either repeated ventricular tap or a chamber or external ventricular drainage in that order. If you are not going to be requiring too frequent a tap, once or twice a tap, sometimes is okay, but it requires repeated tapping, then you can put in a chamber. Okay? Ventricular chamber, so that you can aspirate it through that. What is the advantage of putting a chamber?
Yes, sir. Sir, it will helpful in repeated tapping so that we won't injure the brain parenchyma for repeated tapping.
What happens if you repeatedly injure the brain parenchyma? If you do repeated ventricular tapping, what will happen?
There will be formation of gliosis through the needle tract, which again inhibits the
one. It may be gliosis, or it can call porencephaly.
Porencephaly, yes, sir. Yes, sir.
Okay, so you don't want that to happen. So if the child requires repeated ventricular tapping, you put in a chamber. However, in case the child is significant and purulent ventriculitis, and the child requires continuous drainage, then only you put in a external ventricular drainage. Please understand, external ventricular drainage is not a simple procedure. It is fraught with a lot of complications and problems because CSF is directly draining outside. It
Yes,
is not a
yes, sir.
long-term option. It is just a short-term option to tide over the crisis.
Yes,
Okay,
sir.
like just like putting in a urinary catheter when there is a Florey UTA, it will help for a while, but retaining the catheter for long is going to be counterproductive. So when you put a
Yes, sir.
ventricular ventricular drainage, you should clearly have an exit plan. You say, I'm going to do it for a week and it's
Yes.
not settling down. Either I'm going to convert it, I'm going to take it out, do something. Okay, that's what. Okay.
Yes,
So
sir.
one is
Yes, sir.
shunt infection. Any CS post-operative infection in a child where a VP shunt is there should be viewed seriously. You can't simply wish it off. One. Okay. Next
Yes,
is
sir. Yes.
malfunction. What all malfunction can happen?
Sir, the break in the ventricular catheter
Yes.
or any block in ventricular catheter either in the proximal end or distal end.
Very good. Block. That I think we discussed about block. Cracks we
Yes,
have
sir.
discussed. Then
And any surgical technique error where the inner one placement of the ventricle into the brain caroma instead of the
okay.
ventricle.
Okay. It can be either intraventricular placement or even after putting properly, it can still migrate.
Yes, sir. It will
It can
still
migrate.
migrate, sir.
Because
It
we
can
don't,
migrate, yes,
we are
sir.
not fixing it inside. We have a control only as long as it's going traverses the parenchyma. Once it goes inside
Yes,
the
sir.
ventricle, you don't have a choice. Okay.
Yes, sir. Yes, sir.
Okay. Then anything else?
And intraventricular hemorrhage while putting a ventricular end catheter, sir.
Very good. Intraventricular hemorrhage or hemorrhage can happen elsewhere. Intraventricular hemorrhage happens because you might have injured an intraventricular blood vessel.
Ventricle.
Can
Yes,
injure
sir.
any other vessel which can be dangerous?
Sir, injuring the
Sir, extradural hematomas also can happen due to
Very true.
yes, sir.
Extradural hematoma, why does it happen?
Sir,
During
coop
the
and
shunt.
counter coop injury due to excessive pressure on the dura, sir. That will break the bridging veins, sir.
See, if there's excessive pressure on the dura from inside, it is going to compress the vessels. So why
Yes,
does
sir.
it happen?
Sir, it will rupture the bridging veins, sir.
If there's a pressure, it is going to be pushing it against the skull, right? The dura.
Yes,
So why
sir.
will that
Yes,
cause?
sir.
Yes, sir.
You are right partly, but you have to extend
Excessive,
it.
sir,
So can
excessive drainage of the ventricle.
no,
Excessive
when
drainage of the
excessive drainage, but more than
yes,
excessive
sir.
drainage, anything else.
Sudden decompression of the ventricle.
More than that, it is a technical error where, see, when you're making a burr hole, you're not stripping the dura off the skull.
Yes.
Okay, you're
Yes,
just,
sir.
the moment
Yes,
you
sir.
see a dura bulging, you're making a small
Yes, sir.
puncture wound in the dura,
Yes,
just
sir.
enough for this
Yes,
to
sir.
go, and you are putting it in. In
Yes,
case
sir.
you strip the dura too much from the skull, then
Yes,
whatever
sir.
counter what Jagdish was saying will happen, and the bridging vessels will
Yes, sir.
collapse. There may be extradural
Yes, sir.
hematoma, which can lead to
Yes, sir.
severe problems. I had a patient where a shunt was done
Yes, sir.
by me about 16, 17 years back. Child was doing very, very well. He was in Gulf.
Yes, sir.
He came, he came about last year because of his raised ACT. The shunt which was functioning for 17 years suddenly stopped working. So child shunt had to be revised. I took the help of a
Yes,
neurosurgeon because he was already grown up fellow. He was already 18. Lucky I involved him because when we did try to do a shunt revision, we couldn't replace it the same side, so we put a shunt on the opposite side. In the
yes,
process
sir.
of me manipulating the previous shunt, some part of the dura head sort of caved in, and the child
Yes, sir.
developed acute extradural hematoma with a with a ventricular midline shift. Child almost coned in the ward. Child had to be taken
Yes.
back. Extradural hematoma had to be evacuated. Did a cranioplasty, struggled around and sent. Why I'm saying is this is a technical error which can happen to anybody. You should be aware of it. So when
Yes.
you're doing a BP shunt, do not strip the dura from the ventricles, because if
Yes,
there's a
sir.
bleeding, it will retract inside. You will not even be able to see it. Next thing
Yes,
is
sir. Yes, sir.
during a burr hole, you see the edges of the burr bleeding. How will you control it?
Sir, by keeping the bone wax along the edges of the
Okay, by putting a
ventricle
bone
control, sir.
wax. Because people again try
It
to
is.
cauterize, may not really work. You need to
Yes, sir.
mechanically put a bone wax so that it is sealed completely. Clear?
Yes, sir. Yes, sir.
Okay. So one is extradural hematoma, intraventricular
Okay, sir.
hemorrhage, infective
Yes, sir.
complications, shunt
Shunt
malfunction.
malfunction.
Anything else can
Yes,
happen?
sir. Sir,
Anything else? Shunt mechanically can it happen? Shunt migration.
Sir, shunt
Can a shunt
migration.
migrate? Can a shunt
Yes, sir.
migrate? If it
Yes.
migrates, where all can it migrate?
Sir, it will
What is more common?
migrate.
Most common shunt migration. What is less common? What is the least common?
Sir, more common is that migration of the ventricular end. It will come out. It will be come out from the ventricular end, sir. Most common.
Okay. It can slip down.
And slip down, yes, sir.
Can it slip into the ventricle?
Sir, it will be rare, sir, because
It can happen.
If the rare, it can happen, sir. It may happen.
Yeah, either it can be distal migration, which is more common, or it can be
Yes, sir.
proximal migration, which is less common but possible. I've seen the entire
Yes, sir.
ventricle ligament going inside the brain. What do you do to prevent this?
Sir, we will tie the ventricular catheter in the connector with a silk suture, and we will suture with the pericranium, sir. Pericranium.
Periosteum, a pericranium.
Periosteum.
Okay, so
Yes,
you
sir.
take a
Yes, sir.
non-absorbable suture, fix
Yes,
the
sir.
shunt over the connector, which is plastic. So with a tight silk suture, fix
Yes,
to the
sir.
periosteum so that it doesn't migrate. So migration of shunt is generally because of a technical failure.
Yes.
Okay.
Yes, sir.
Then what are the other complications?
Sir, late complications, sir. Late complication, again, it is the complication in the proximal end as distal end. In proximal end, there is a shunt obstruction, sir. Like because of overgrowth of brain parenchyma or gliosis, will cause shunt blockage.
Or what else? Ventricular can be blocked because of overgrowth of the brain tissue inside, gliosis, anything else?
Gliosis.
Within the ventricle, anything else can grow inside? Shunt migration into the brain parenchyma, or sometimes even the ependymal cells can overgrow into this.
Yes, sir. Ependymal cells.
So this is from the ventricular end.
Yes, sir.
Okay.
Yes, sir. Distal
Anything
end,
else in the ventricular end?
Sir, ventricular end. Again, other complication like split ventricle syndrome occurs, sir.
That is again at the ventricular end. Okay.
Yes, sir. So distal end. Yes, sir. Peritoneal end, it may cause additional intestinal obstruction, CSF cirrhosis, a bowel injury, penetration of the distal end into the bowel wall.
Okay.
Or a migration of shunt into the either inguinal canal or into the umbilical
Very good. Very good. Anything else?
And because of addition, shunt blockage, sir.
Okay. Sometimes there can be volvulus of bowel over the shunt. Okay, around the shunt.
Yes, sir. Yes,
okay,
sir.
what I said is fine. And then sometimes it can migrate into the rectum, and we have seen the catheter coming out of the rectum.
Yes,
okay.
Sir. Yes, sir.
And in these cases, will there be meningitis because it's coming to the bowel or the rectum? Will there be a shunt in meningitis?
Sir, since it is a one-way valve at the valve level, the chance of meningitis will be less, sir.
Very good. One because of valve. Anything else? Anything else? Okay. One more reason is that all this shunt migration into the bowel or the rectum is a slow invasion. Okay. It is a penetration. It's not a perforation and going in directly. It's not like a surgical injury. So basically it's a penetration. So it's a chronic process by which it goes through it. So it sort of burrows inside and comes out. There will be no peritonitis and there will be no ventriculitis. How do you manage this? If I see a shunt coming out and I've taken a picture where shunt is still functioning. Karma Yogi.
Sir, still, if the shunt is still functioning, still I will remove the VP shunt and change into the reservoir, sir. Initially.
What is the precaution? Why reservoir, man? Why are you fond of the reservoir? See, this child has got no peritonitis, no ventriculitis. The ventricular tip distal end has migrated through the rectum and is coming out. You can see it per annum and it is dripping.
Yes, sir. Yes, sir.
So what will you do? Can I just pull it back and put it inside the peritoneum?
No, no, sir. No, sir.
So what will you do?
I will go for I will convert the shunt into the external drainage.
Why the hell? I am telling you, Sridhar, repeatedly, external ventricular drainage is only rare indication where there is a purulent ventriculitis. This child does not have. So what will you do?
I will change the VP shunts. I will remove
First
the shunt
class.
and I will change the VP shunts, sir.
Yeah,
Yes,
I will revise the shunt, particularly the peritoneal end. Okay, if the ventricular end
Yes,
is
sir.
functioning well, you don't
Yes,
really require to. So you just can make an incision over the chamber, just
Yes,
disconnect
sir.
the distal part.
Yes,
And what
sir.
is the precaution you're going to take? How are you going to pull out the catheter? Will you pull it proximally or distally?
Sir, distally, sir.
Jago,
Distally,
distally.
sir.
You don't want the rectal
Yes, sir.
content to come back. Okay.
Yes, sir.
So
Yes, sir.
you pull the distal end and pull it out. Like I showed it to
Yes, sir.
somebody last time, a shunt which is there for longer time generally will develop
Yes,
a
sir.
synovial sheath sort of thing. It easily
Yes, sir.
glides through that. Okay.
Yes,
So
sir.
all you
Yes, sir.
require to do is to detach the ventricular end, the peritoneal
Yes,
end
sir.
from the chamber, tug it from below, generally it comes out. Most of the
Yes,
times
sir.
you can use the same route through which you can put in a fresh shunt. It can go inside the
Yes, sir.
peritoneum. If not, you
Yes,
can
sir.
create a new tunnel and do it. All right. And there's no role for chamber. There's no role for external ventricular drainage because it's a
Yes,
normal
sir.
ventricle without any meningitis. You just
Yes,
got to
sir.
replace
Yes.
it. All right.
Yes, sir.
Same
Yes,
applies
sir.
if there is coming out of the umbilicus.
Yes, sir. Yes,
All
sir.
right. What are the other things long term can happen? Because I told you
Long
at least I got
term.
5 or 6 babies. I got 5.
Yes,
I'll
sir.
put it this way. I got 5 or 6 babies. No, I've done a shunt 20
Yes,
years
sir.
back and they functioned well. But I'm
Yes,
not
sir.
lucky all the time. So is
Yes.
everybody. So what are the other
Yes,
things
sir.
which can happen?
CSF pseudocyst, sir.
Very
And,
good. So what is the reason for pseudocyst and how do you handle it?
sir, the reason for pseudocyst is the CSF, the absorptive surface of the peritoneum will become less, and the CSF will be collected and form a cyst, sir, in which is collected in the non-absorbable area of the peritoneum. The managing is that a laparotomy or laparoscopy and deroofing of the cyst and replace the ventricular, peritoneal end of the catheter in the subdiaphragmatic area, sir.
Sridhar, Jagdish, will you agree with him?
It is the protein in the CSF which is irritating the peritoneum and causing the bowel aggregation there and forming a cyst sort of thing. That is the etiology which I understood, sir. And
Okay.
the management wise, the drainage of a pseudocyst and the deroofing of a cyst and placement of the distal catheter into the supradiaphragmatic surface,
Okay.
preferably on right side is
Okay.
done, sir.
Okay, I'll tell you my concept. I want Murali, Gauri and Ramachandra sir to add after that. My concept is it's because of a peritoneal reaction that it tends to sort of make a loculated collection of CSF in the peritoneum.
Yes.
The moment it happens, the CSF pseudocyst, there's a high chance of recurrence even if you put it a different way because the peritoneum may react the same way. However, since we will still try to give as much options as possible by draining the CSF pseudocyst either by laparoscopy or by laparotomy and we're pushing it in elsewhere. In a normal VP shunt also, we're trying to put it in the supradiaphragmatic area to reduce the reaction of the bowel and to bowel related complication. However, even if you put it in the supradiaphragmatic area, there's no guarantee that it will stay there. It can still migrate to rest of the peritoneum. So the management of pseudocyst may be easy initially, but a recurrent pseudocyst may really pose a problem. I want now Gauri and Murali and Ramachandra sir to please add to what I'm saying and if there is any different viewpoint.
No,
Nothing, sir.
No, let me answer.
Sir.
Pseudocyst is just an unlucky one-off incident which happens in a baby. Very rarely it recurs. So the treatment is preferably laparoscopy nowadays. So it's very easy to do it laparoscopically. You have to just follow the entry point, just take it as the guideline, follow the entry point, go to the pseudocyst, and as Sridhar said, you unroof the pseudocyst. So you make a wide opening and try to retrieve the end back into the peritoneal cavity. So from the point where it enters the pseudocyst, you have to retrieve it back and put it back into the pelvis. Most often the pseudocyst will be either in the one quadrant of the abdomen, so you put it in the other quadrant of the abdomen. So that is all that is required, and very often that will work. So nothing more is required for that, and it is not diaphragmatic, it is subdiaphragmatic, suprahepatic, which most of us used to do. But nowadays, neurosurgery and most of us would put the shunt tubing, intra-abdominal shunt tubing into the pelvis. That is the preferred spot. And you leave the entire length into the pelvis. That is the preferred technique.
Sir, any specific reason why we are placing in the pelvis, sir?
No, the length, preferably the length you maintain so that you take care of the growth. When the child grows, it takes up the growth of the child.
This is the next question I was about to ask. Go ahead.
Sir, the tendency of again reforming cyst will be the same when we place in the pelvic cavity, sir.
No.
Generally, pseudocyst is on one-off event. It generally does not recur. If it happens, it's a very, very unfortunate thing to redo the same thing. If it happens again and again, then you have to do a ventricular-pleural shunt or change it into a ventricular-atrial shunt.
Atrial shunt, yes, sir.
Okay, sir.
Murali, something?
Yes, sir. See, the main one is the length. As sir said, length of the shunt which is required. So that is one reason for placing it in the pelvis. And the another reason is this subdiaphragmatic region and pelvic region, they have rich lymphatic supply. So it helps in better absorption of CSF compared to other areas of peritoneum. That's what people have seen because of dense lymphatic plexus in both the pelvis and in the subdiaphragmatic region. So that's why they preferably place the shunt tube there. I mean, so it is theoretically supposed to reduce the incidence of cyst formation, but it doesn't happen always.
Yes.
Hello.
Okay. I'm hearing. Gauri, you're saying something?
My question was, when we place it on subdiaphragmatic space, the accessibility of the tubing to the bowel and rest of the things will be less when compared with the pelvis. When we are placing, in spite of placing it there, keeping the pelvis, I think more accessible for the bowel to adhere there and the momentum to go there.
Jagdish, that's what I answered you. Yeah.
Sir.
Jagdish, like sir has mentioned, Ram sir also mentioned it, it's an one-off incident and it's an unfortunate incident which should not occur. It could be a subclinical infection or it could be just a chemical peritonitis. So either you, as Murali pointed out, the studies done showed because of the movement of flow, if you see the infection or peritonitis going through the lateral paracolic folds, that's the subdiaphragmatic is one of the richest areas. So that was the one of the reason why it was placed, that's it, and to be safe away from bowel. But if you many times you take an X-ray, most of the times it comes back to normal, so it will be lying in the abdomen. So when it occurs, we need to go and manage it. So you upfront give it in pelvis. Many times even after you done put it subliver, you are not going to fix it. You are going to leave it alone. So then it will definitely come back and it will be lying in the pelvis, and also you'll get additional length, so that follows to incorporate for the growth of the child. Yes.
Okay, that's what I was trying to tell. Conventionally, we are taught to place it, even though the conventional BP to place it above the liver so that it reduces the exposure and bowel-related complication. That is theoretical. Practically, as I said, if you just see, for example, how to assess the ventricular tip or this thing, peritoneal tip, what investigation you can do?
No, sir. Ultrasound sometimes you can able to
plain X-ray. Okay, even a plain X-ray, because it is a radio opaque thing that you can see. It is a radio thing, if not radio opaque. So if you simply, even after a conventional V patient where you put it above the liver, okay, just take an X-ray after about 3-4 weeks. I have done it in several cases, just as a curiosity. You realize that it is not in the subliver, or suprahepatic area, it migrates elsewhere. So even though you put it, it's only for a satisfaction, it can still end up migrating. Like we said, it is good if it is a single cyst, but if it is recurrent, it is always a headache. All right.
Yes, sir.
So it's a pseudocyst. Okay. Any other complications can happen?
Distortion.
This is related to what Ramachandra sir highlighted. The child grows, shunt will not grow. So what may happen?
It will be proximal. The pull of the tip will. The length of the distal catheter won't be enough to the height of the child, sir. So it will get pulled out.
Again, repeatedly, I'm telling you, Sridhar, don't say will, won't, and all. It may.
Sorry, sir. It may be. Yes, sir. The length of the distal catheter may not be enough to.
So what happens?
Accommodate the growth of the child.
So what happens?
Distal end of the catheter may be pulled into the abdominal wall, sir. and it will give to shunt
Abdominal wall.
blockage. Yes, sir.
Very true. So
Yes.
the distal end of the V patient may migrate out into the abdominal wall or may be pulled up, and
Yes, sir.
the CSF may be draining into an area which is non-absorptive. Okay.
Yes, sir.
So either
Yes, sir.
first, what will you get? More than obstructed hydrocephalus, what will you get?
Get to that localized swelling.
So what is it called? What is it called technically? Jagu? Some people refer it as a CSF hygroma.
CSF
Collection
hygroma. Yes, sir.
like a
Yes,
cystic
sir.
hygroma. Okay.
Yes, sir.
It is all right. I'm not saying that's the only way, but it's
Yes,
better
sir.
to know about it. It can cause a
Yes, sir.
CSF hygroma. So management of it is you have to assess what is the length and then go ahead.
Yes, sir.
Okay.
Yes, sir. Yes, sir.
So sometimes the entire thing may detach and go into the abdomen cavity. Like I was telling, our neurosurgical friend has called me twice or thrice that the entire
Yes, sir.
peritoneal end has migrated into the peritoneum under a laparoscopy and removal. Okay. So you can do all
Yes,
those
sir.
things.
Yes, sir.
So I think we have covered most of the things on hydrocephalus. But after all these complications, in case you require
Yes,
to revise the shunt because the child is not tolerating VP shunt, recurrent series
Yes,
of pseudosis, what are the
Yes, sir.
alternatives and how do you do each one of them?
Sir, the alternative steps are one is a ventricular atrial shunt can be used, sir.
Ventricular?
Other one is a atrial shunt.
Okay. When you do ventricular atrial shunt,
Yes, sir.
where is the tip and how do you access that area? How do you introduce it?
Sir, the tip is at the level of the junction of superior vena cava and the right atrium, sir.
Okay. And how do you reach
So,
that?
either with ultrasound guided Seldinger technique or
How do which part of the which vessel
Yes,
do you
sir.
open to introduce the shunt to reach that area?
internal jugular vein, sir. Internal jugular
No.
vein.
No.
Yes, sir.
It is usually access it through the common facial vein. Okay. Intrajugular vein, you don't want to cut and damage and compromise. So most of us,
Yes.
this is my practice. Again, there may be variations if others can add in. We normally used to do is you identify and get the common facial vein, ligate it proximally because it's a what you call dispensable vein, and the distal
Yes,
part of it we used to pass the shunt through the
Yes, sir.
common facial vein into the intrajugular into the superior vena cava. Okay, and keep it there. Others can add it. And what is the advantage? What is the disadvantage?
Seldinger technique
Sir.
also is accepted.
Okay, Celtic is the first class. Accepted, sir. Accepted.
Yeah, just like
If
you
you do it, cut down, this a bit.
just like you do for chemoport insertion. That's all.
Fair
basically.
enough. Fair enough. Fair enough.
So you can use the
Ventricular
you can use the extrajugular vein also. That's also
okay, sir. What we used to do was we used to at least I've done a couple of them during my MCH days.
Common facial.
What we used to do is to go common facial. We used to do a cut down and use a vein pick and put it inside, sir.
Yes,
Okay.
Yes, sir.
What is the advantage of a VA shunt? What is the disadvantage of VP shunt? VA shunt, and why is it not commonly done?
Sir, advantage of the VA shunt is that the chance of distal blockage will be less, sir. And the
Very good.
CSF immediately goes to the blood vessel. Disadvantage is that there is a increased chance of pulmonary embolism and
Thromboembolism.
thromboembolism will be there, sir. Increased chances of.
Okay. Another
And
thing? What is the biggest disadvantage of putting a VA shunt in a child?
Again the child will grow and we can't keep the excessive length of the distal catheter, sir.
Yes.
So if the child grows, the catheter there is more chance for revision is needed.
Okay. So it's difficult to calibrate for the child's growth. You can't factor into that. So even though you make a perfect placement in the beginning, as the child grows, it may again go back. So VA shunt is generally not preferred except as a salvage procedure. Okay.
Yes,
what are other types of shunts that you can do? But Gauri, Murali, and Ram sir, you want to add anything on the VA shunt? Because this is something not routinely done. So it is better that all of them know about it.
No, nothing more. Nothing.
Okay. Another third choice will be the ventricular pleural shunt is used, sir.
Okay.
Again, either through thoracoscopic guidance or thoracotomy, we can do ventricular pleural shunt. But the disadvantage is that the absorptive surface is less, so there is more chances of formation of pleural effusion will be there, sir.
Okay. I don't know about the utility of thoracoscopy because you're going to put it anyway in the pleural cavity. You don't really require a guidance for that. I don't think thoracoscopy is useful. Yeah, come back, Gauri.
Only thing in the ventricular atrial shunt is that what they use the Raymond's type, where it is coiled in, and so it is in the device is in the chest, thorax inside. So as the
Okay.
child grows, it sort of unwinds itself and lengthens. So that is one device which is used if they're using
What is it called, Gauri?
atrial shunt.
What is it called? Raymond's.
Raymond
Okay.
shunt.
Okay.
So that's a little older. I mean, I've not updated my recent this thing. But
Okay.
it is sort of a tape-like thing, and it uncoils itself as the child grows. So one end is in the ventricle, other end is this. That is to avoid repeated intervention.
Interventions. Okay, excellent.
Yes, sir. Yes, sir.
Ventricular pleural shunt again is seldom done because the
Yes, sir.
cases where the pleural cavity is, I mean, peritoneum is not accepting for whatever reason, the pleural cavity is also likely to be the same. So it may not really work. Okay, but anyway, that's one thing to make. What are the other methods by which you can do?
Another
What
is
other options?
ventricular subcalial shunt is preferred, sir. But again, it is a temporary machine. Yes, sir.
Okay,
It's a
or
temporary
thecoatrial
measure.
shunt. Ventricular thecal shunt or something. I don't remember. Murali, correct me.
Yes, sir. Yeah. Ventriculothecal.
Okay. That apart, anything else can be done as a surgeon, general surgeon. What is described? You need to know because we're not going to keep discussing this again. So might as well complete the discussion. What are the other places where you can put the tip of the ventricular the shunt?
It is described to put the tip in the gallbladder, sir.
Good.
Someone also tried in the urinary bladder also, distal end of the
More than not urinary bladder. It's not urinary. Where else?
Ureter.
Ureter.
How do you put it in the ureter?
I don't know, sir.
Okay. Basically, there are two ways to do it. One, you can just make an opening and put the tip inside the ureter and fix it. But very many times we may not be happy, so we may want to do a TUU, cut it and put it in the distal ureter. Okay. However, these things are rare. These are not routinely done, but this is a rare case that you can do. Anybody? Okay. If there's nothing else, I would like to, on a lighter note, I would like to say one thing. I had a unfortunate experience during my MCS days to witness one child by name Dhananjay. I cannot forget that fellow. He had undergone multiple VP shunts, not worked. VA shunts did not work. Ventricular pleural did not work. Finally, he did a ventricular atrial shunt. And that fellow finally went into obviously into a coma stage. It was just like our Anand in Munnabai MBBS. He was in a vegetative state. But my professor boss never gave up. Ela Mishra used to go every day and call him lovingly, Dhananjay, Utho. And that the common refrain between me and Gopal and Anand, who used to see from back, we used to say, Madam, be happy that he's not getting up. If he gets up, first thing he's going to do is slap you. Anyway, so it is unfortunate case. It can happen. So, but it is good to know the various types of shunts that you use. Last two questions, at least from my side. One is, when you do a VP shunt, you said the child will grow, the shunt will not grow. You are about to close?
Yes, sir. Another 3-4 minutes.
Okay, I will finish my questions. One is, what is to prevent it? Either some people put in the whole length of shunt inside without trimming. Some people put long. What is the advantage, disadvantage of both? You understand what I'm saying? Many of us trim the peritoneal end. Some people do not trim.
Yes, sir.
Okay, I'll just complete it. The advantage of not removing it and putting the entire thing, like Ashley used to do, Ashley DeCruz used to put the entire length of the shunt. Advantage is to say they don't require to revise it because the child that will withstand the child for long. The disadvantage is there's too much of a shunt being coiled. It is likely to sort of move around and may cause a problem. I've seen quite a few patients. So I generally put at least about 20 centimeters inside because generally that takes care of growth for the at least till about puberty. Most of the cases I have got away with it. I don't know the practice of others. Murali, Ramachandra sir and Gauri?
Yes, sir.
What do you prefer? You prefer to trim the distal end or distal end in the sense proximal part of the peritoneal end of the tube?
No, sir. Won't be cutting that.
Okay. Some people don't cut, some people. Murali?
No, sir.
Okay, it's up to them. I prefer to cut, but some people don't. Either way is okay. Last question is the head circumference at birth and what is the rate at which it will grow and what is the head circumference at 1 year of age. So how will you identify Hydrocephalus based on the the head circumference.
Sir, head circumference at birth will be 32 to 35 centimeter range, where in the first 3 months it increased by 2 centimeter per month, and the next, the 4th to 6th month it increased by 1 centimeter per month, and from 7th month to 12th month it increases 0.5 centimeter per month for next 6
If you
months.
total this, it will be much more than 10 centimeters.
Yes, sir, 12 centimeters. So if the head circumference at birth 35, up to 47 centimeter at the age of 1 year will be a normal size.
From what I remember as a thumb rule was 35 general, plus minus you can keep, but 35 is generally the head circumference at birth for a normal baby. At 1 year, it will be 45 centimeter, 10 centimeter increase. First 6 months, it will be 2 centimeter per month. Then it will be 1 centimeter for the next 3 months. And then it will be half centimeter per month. It will come to around 12 centimeter, but it's okay. It's a rough thumb rule. But this is important, mainly if you know the head circumference earlier. This we are talking about a normal newborn, where head circumference at birth is not known. However, head circumference for anywhere between 32 to 35 centimeters is acceptable. Murali, Gauri, and Ramachandra sir, I am through with my questioning. Anything you want to add, please add.
No, we are fine. I'm fine.
We are fine, sir. Sure, sir.
Yeah,
Murali?
sir, you need to know about arrested hydrocephalus, that is one, and and ETV.
Yes, sir.
Yeah, so these are two things you need to know about.
Third thing is about normal pressure hydrocephalus, which we did not ask. And then we may ask you about CSF